Hi, everyone. We are just testing our cameras back there. We should probably be ready to go in a few minutes. Okay. Thank you for your patience. Broadcasting this live, so this is why it's taking a few minutes, because we told everyone online that we were going to get on at 1:45. So it's exciting that we are broadcasting this to LA, to Sacramento, to Hawaii. Anyone who has access to the internet. Yeah. And my name is Jennifer Nancy, and I am the Director of Marketing and Communications for the ALS Association Golden West Chapter. Thank you all for coming today. I just wanted to say that even though this is being webcast live, you are not on camera, and if you do choose to, ask a question, just the back of your head would be seen on camera. If you do not wish to be seen on camera, you could also ask one of us to ask your question on your behalf. And then when we do get to the question and answer portions, we will take all the questions from the audience first, and then we'll take questions from the internet. So we'll be starting in just a second.
So we don't need to sign a waiver.
Sorry, this is just taking a moment.
Yeah, I'm assistant engineer too, so. Sometimes it's like a DNS issue or something.
I'm already on the number. I'm there, I think. As long as that kicks back over. Great. So as soon as you can can start this PowerPoint. Then we're ready to go.
Should I stand here or where should I stand? Where should I stand here? Good afternoon, everyone. I want to first thank everybody for taking the time out of their Saturday, our first non-rainy day all week here in San Diego. Thank you, our ALS families in San Diego, Orange County, Golden West, and we also have some families represented from Hawaii as well, which is fantastic. I want to first start out with introducing myself really briefly. My name is Larissa Kerstetter. I'm the new Director of Development at the San Diego County ALS chapter. I just started November, so I'm kind of new and haven't met a lot of you. So I'm hoping to meet you over the next course of the year in 2016. And we're so pleased that that Golden West has given us the opportunity to help host this first Ask the Experts for San Diego. It's been truly an honor working with such professionals, and to be able to bring this knowledge to our community is just fantastic. So I want to welcome also the online community watching via webcast to this event, and we'll just kind of go over the program schedule. We're going to have Dr. Ravits speak first. He's going to give about a 5-minute speech. We'll break then for a few Q&As, and then we're going to have our panel come up and each do a speech, about 5 minutes, and then do a 10-minute Q&A after their topics. So I would like to introduce Dr. John Ravits. He is a professor of clinical neuroscience at UCSD, and he will be talking about the first topic in the agenda. So thank you again.
Thank you very much. It's a pleasure to be here. I thought I was going to speak for 45 minutes with a detailed scientific, but about 10 minutes, what I'd like to do is about 10 minutes to just tell you a little bit about my perspective on dealing with ALS, and then open it up to questions, because I think those are the liveliest and most important part of the presentation. So I think I called the presentation today Navigating Difficult Waters. And the reason I chose that topic is because I've been dealing with ALS as a clinical neurologist for, I don't want to say how many decades, but about 30 years. And so during that time, I have seen lots of questions, and I feel like I have a pretty good appreciation for what patients are going through as they're getting diagnosed and as they're going through the navigating through their disease. And I know how complicated it is. And so I'm going to try to point out how I like to guide people and to guide them through the journey of the disease. And as I think about it, I always, in my mind, divide ALS into kind of 3 phases. And probably the most important and most difficult and the most artful as a clinical neurologist is dealing with the diagnosis. And I have a private theory that's will be hard to prove, but I think that the quality of life of an ALS patient is determined by the way the diagnosis is made and presented. And it doesn't really matter whether the patient has a rapid course or a very slow course. The delicacy of those early months to me is the most critical, so that patients can get their arms around their diagnosis emotionally and come to terms with it. And I think so there's a huge role for the neurologist in that process, and I'll come back to that. So let's just talk a little bit about that. So what I've learned is that many patients are fairly abruptly and bluntly told the diagnosis. And for something this complicated, for most people relatively unknown at the time of the diagnosis, it can be a very jarring experience. And yet if it's done gently, and it's a process that sometimes takes months, sometimes takes years, But if it's done in a gentle way and to transition the patients into the diagnosis, then there can be an acceptance and there can be a real spirit, to then go on and deal with the disease. So I have different tricks in which I try to do that. But just to emphasize that, to me, stage one is really presenting the diagnosis and making the patient and their family and everybody not necessarily at peace with it, but to kind of come to grips with with what they have before them. And so some of the ways in which I do that is I ask the patient, what do you think is wrong? You've been having problems with walking or talking or with your coordination or whatever, and what do you think is going on? And that's hugely important for me because it tells me where they're at. And I oftentimes will then go around, I see many of my own patients here, so you can tell me if I did the same to you, as I'll go around to everybody in the room, family or who's ever accompanying them, and ask everybody to sort of tell me what they think so that I know then where I should begin my discussion. And as you can imagine, I hear all kinds of things from people knowing exactly what they have to people not knowing and not being relatively clueless about what's going on. And so at least I know where to begin. And that's a critical step in discussing with patients. Turns out most of the time, ALS is not a difficult diagnosis for a clinical neurologist. So sometimes there's a lot of testing, but oftentimes it's not hard, or by the time they get to me and they've had testing and important preliminary testing and things like that, then I'm not confused by the diagnosis. The important thing is to present the diagnosis. Okay, then the second stage, which is the really roll up your sleeves and go to work, is really what you're going to hear more about today, is caring for the patients, because that's really the vital part of what we do in a multidisciplinary clinic, is deal with the issues that are related to communications and balance and nutrition and so on. And for that, there's an incredible team. My folks here at UCSD are going to be talking to you, and you'll have plenty of chance to hear about their perspective and what they do and they'll help answer your questions. And then at some point for many patients, we all know where it's heading, and it gets into advanced stages and it gets more delicate in terms of the discussion. I'm not here to talk about that because I actually don't like talking about it to a patient until it's really time to have more advanced discussions. But that's my duty as well. But the challenge for me is if you have those discussions early, it's a downer, and there's so much life before the disease advances that you're kind of eclipsing and losing track of what's really important. And so the key thing for the patient is to keep active, to keep doing everything that you possibly can do, and stay and do the stuff that's fulfilling. And that's true for all of us, but it's particularly true for the ALS patient, and not to be too focused on the negative aspects. So the way the ALS Association always talks about that is living with ALS, not dying with ALS. And I think that's so true. And certainly I think for the patients, getting into advanced discussions is not appropriate, because you want to do all the medical care that you can do while it's appropriate. And that can be for several years or longer. And some patients will go into remissions. So there's all these sorts of positive things that can happen. And so again, not to get too far ahead and to keep people energized. Now, one of the things that keeps me going is the research that's going on, because this field is just exploding. I think in all of neuroscience and all of neurology, ALS has gone from being a niche disease that nobody knew much about to being something like it's in the spotlight of neurology, because of all of the advances in understanding the genetics and the mechanisms and the biology, and in addition, it's now recruiting all kinds of attention from the pharmaceutical industry, which previously had big challenges trying to develop drugs for for neurological disease. It's just a tough area for drug development, and it intimidated a lot of companies from a business model. And now all of a sudden we're just seeing the opposite. All of a sudden all kinds of people are coming into it with all kinds of ideas and all kinds of approaches, and it's never been more exciting in my career than the things that are going on now. But drug development is a tough course, and so we understand that the ideas that are ideas now may take 5 or 10 years to develop, but the key point is that they are developing, and everybody hopefully will have a way to contribute to this effort. So if it's not for us, it'll be for the next generation of neurologists and patients. So that's a key part, I think, of the clinical care is the research, and it's kind of unique among diseases, I think, because if you had high blood pressure, you don't go to the doctor and expect to have research. I mean, you just expect what's the template, what's the best approach. Same for osteoporosis or whatever. But with a disease like ALS, we're all kind of in this together. And so the research and the clinical care are very nicely intertwined and aligned, so that the things we need to do to advance the research is also the things that we do to advance the patient care. And so that's one of the wonderful parts about dealing with ALS is this alignment and this sense of urgency and energy. In particular, what's going on today is the California meeting, and I just want to shout out a little bit about the stuff that's happening in the state of California, because here in particular is just a factory of research, of ideas, of drug development, and I think of any place maybe in the world, California has tremendous concentration of resources and potential all up and down, throughout the state. And so one of the things that we do is we meet once a year. There's a lot of collaborations that go on through the year, but this is the 6th year that we're all meeting together, and it rotates throughout the state. Last year was in San Francisco, the year before in Fresno, in LA a couple years, and now it's San Diego's turn. And at the end of the day, we'll also decide where next year's meeting is going to go. But it's really exciting to see how big the meeting is and how much bigger it's getting. And what we do is we get together with the clinicians, the scientists, the pharmaceutical industry, the funders, the ALS Association. And so it's a wonderful intermix of everybody who's interested in ALS and how we share, and we kind of just rotate the podium. And the meeting is really one of the best meetings that I go to during the year. So I'm very excited to be a part of it. I'm the host this year. And then we get to then now entertain the San Diego community, and I guess we're doing it throughout the state also on the web broadcast. And again, to just show the kind of interface and the connection that we have. So I think I'll stop there. Those are the things I wanted to say, and it's I want to open it up to questions because I know there are a bunch of them.
What would be one or two of the most promising new developments?
So the question is, what are one or two of the most promising new developments? So I'm going to I'll mention two, and they're very very different. One is the new gene therapies. So as you may or may not know, ALS about 10% of the time is genetic. In the genetic 10%, there's a gene. So the gene has a mutation, and that's, we know, causes the disease. So now there are therapies that can then target that gene. So you can target the mutation or the gene that's mutated, and then try to basically take away the toxic part of that mutation. Those therapies have actually been developed in the San Diego area in Carlsbad at a company called Ionis, which has been working on this kind of therapy for about 20 years. And they tried initially for inflammatory disease and for cancer and for others. And about 10 or 15 years ago, they started thinking about neurogenetic diseases. And those are now going live. So we're going to be starting that 6 places in the U.S., including San Diego, and then 6 places in Europe. And we'll be starting the early, what I call phase 1 studies. Now, that to me is the single most exciting development that's going on. The problem with it is that it's for a very niche, small percent of patients. And so the genetics gets a lot of attention, disproportionate attention, because it's a minority patient, but gets the majority of the research. And so let me just clarify why that is. We all know that sporadic disease is the thing we're after. But since we don't know what we're dealing with and we don't know how to attack it, it's much harder. Whereas with the genetic disease, we can swim upstream to that mutation and then start trying to pile on that. And if we can get that to work, we know we got something. So I think it's getting a lot of attention, but we know what the bigger prize is all about. The second thing I'll mention is stem cells, because it's on most people's minds and everybody's hearing about it. California in particular is a powerhouse of stem cell research. It's going on in a couple places in the country. There's a lot of sort of marginal claims about stem cells outside of the big science center, so I'm not sure I want to get into that. But stem cells is something that everybody is excited about and thinking about and asks about. But and that's we're going to hear more about that in the upcoming couple of years. Some new studies are going to launch, and it'll go forward, but slowly. And one of the problems, from my point of view, there's two major problems with the stem cells in terms of trying to apply it to ALS. The first is the delivery. It's by surgery. So you have to do what, to me, is a huge surgery, opening up the spinal cord and then putting in the delivery. That's called cell therapeutics. You're delivering the stem cells, implanting them, and hoping they'll stay. So that is a huge surgery for somebody who's sick. And then the second problem is that the disease is all over the place. So it's like giving an antibiotic to an infection that's systemic. So stem cells can only deliver within a region of the zone of where they're delivered. And whereas we have a disease that's up in the brainstem or in the brain or all throughout the spinal cord. And so it wouldn't, even if it works, it wouldn't work in the areas that are remote. So that's a big challenge as we go forward. I think the first challenge is, do they work? And can we get them to work in a region? And then if we can get them to work in a region, can we then roll that out to other parts of the nervous system? So that's not to put a downer on the stem cells, but to be realistic about how this therapy is going to go forward.
For active studies that are going on right now where they're actively looking for volunteers, how do you move through that and know, do I need that? Can you hear me?
Yeah, you go ahead, because they have to hear it on the web.
Okay, for active studies that are going on, for studies that are going on, how do you swim through it and figure out, are you a candidate for that? Can that be something that could help you? I mean, obviously you might be a placebo person, but is that something that, as a patient, current patient?
Yes, okay, gotcha. Okay, the question that she asked is basically, how do you find out about clinical trials and how do you get into them?
Yeah, you can see them, but then there's South Carolina, Kansas. Is it worth putting your patient through that?
Sure. But for some of the people, they don't even know how to find them. So let me just make sure that they're able to find it. So there's clinical care and there's clinical trials. When you go to your doctor, you're seeing your doctor, and that's clinical care. And that's a alliance between you and the medical center and the providers, and that's clinical care. Somebody can go one place for their clinical care, but their clinical trials, which is research, which is separate from providing for you or meeting your needs. It's doing a research project and getting you access to drugs that might work. And those you can go anywhere for. So you don't have to be at one, you don't have to go to UCSD to get into our clinical trials, and vice versa. You can be our patient and then go elsewhere where there's a clinical trial. How do you find out about them? There's websites. So you go to what's called clinicaltrials.gov. It's a clearinghouse by the government to clear all clinical trials, and that for every disease. So you just go into that and then put in ALS, and then that will tell you where the active clinical trials or the status of that trial is. There's also the ALS Association has a website, and there's other places where you can learn about clinical trials. when you go into a clinical trial, there's inclusion and exclusion, because if you think of what you're trying to do, you're trying to prove, does this drug change the course of the disease? Does it help the disease? And so generally they're placebo controlled. So a placebo is a fake or a sham, and and they're called prospective placebo controlled double blind. And what that means is you're giving a drug and then you're following their progression, see if it changes. Prospective placebo controlled means half the patient will get a placebo, half will get a drug, or sometimes it's one third and 2/3. Double blind, and that means that the patients don't know and the people doing the testing don't know, because we don't want to be biased. We all want something to work, and so you can introduce bias and be misled. So you have prospective placebo-controlled double-blind trials. And there are just strict inclusion and exclusion, as to be, in part because you want to kind of be entering the same patient in one region where you're doing it in other parts around the country. And so you can be eligible for one but not for another. They don't necessarily line up. Generally, they're geared for early stage patients. Usually there's a respiratory measurement that you have to meet, and that's for protection and safety. So there's all kinds of safeguards that are built into it.
In the clinical trial, so if you were to travel out of state to go to a clinical trial, what's actually expected of the patient, like follow-up wise? Is it something that you can go home and then go back to that doctor for follow-up visits, or do you have to stay there for like a certain duration?
Yeah, so the question has to do with what are your commitments or obligations to the study site. Generally, you don't have to live there. Generally, the rule is most studies will have patients come back once a month. So you have to be willing to come back once a month. If there are things we can do local or there's interim things, those can all be sort of flexed and arranged, but generally once a month.
How is the research going with the HIV virus? Oh, the research for the HIV virus that some doctor thought might cause ALS.
Yeah, so the question has to do with, it's actually called an endogenous retrovirus. And so how is it going for therapeutic trials? So let's back up to get everybody on the story. So the story was a report about a couple of months ago, 1 or 2 months ago, was a report that there is something, it's not HIV, so it's not HIV, but it's a virus that has behaviors that are called retroviral. It's basically the way that a virus can move along. And there are things that we're born with. It turns out a huge part of our genetics is endogenous retroviruses that got stuck into our genome through evolution. So it's been a kind of a frontier. It's a very complicated area of research, but there was some recent report, that it may be more active in ALS patients. Then raising the question whether antiretroviral therapy, which we have pretty well refined for HIV, which is a retrovirus, whether that might work. So there's arguments both ways. One argument is if we don't know what we're doing and we don't get our ducks lined up first, we're going to do the therapy like all the other drug trials we've done and then miss it. And if it doesn't work, we're going to say it doesn't work when we haven't properly tested the right patients and all of that. So there's some discussions going on in the background. Some people say, well, let's just do it. And we know we have a lot of experience with that. And so that's kind of the debate right now as to how soon and how much more information to get. And there's obviously arguments each way.
Would mycoplasma be in that same category?
Would
what?
mycoplasma bacteria infection be in that same category?
No, chronic mycoplasma or mycoplasma infection. No, I would put that more in the category of something like Lyme disease. There's a literature on Lyme disease, which I'm sure many of you have read about. Mycoplasma. Some of these chronic infections, there really is not any evidence to support that they play a role in ALS. So those discussions go back decades, because patients, I think, for a long time have been asking about that or trying it. And the evidence is not, to me, as exciting as what's come out recently for these new elements.
If you were to sign up for an ALS clinical trial, how long about would it take for you to, If you were to sign up for an ALS clinical trial, how long would it take before you were accepted, or is it a lengthy process, or?
Yeah, I think everybody heard the question, so I don't need to repeat it. No, it's not lengthy. They can screen you on the phone. So for some patients, especially if you're going a long distance, if it's not worth your while, they can sometimes screen some things by phone. But otherwise, you can go there, and you either qualify or you don't. If you qualify, generally you're in.
Your personal thoughts on clinical studies currently going on in California?
The portfolio of trials that are going on, there's a lot. I mean, there's a big study now that's going on internationally, which is the cytokinetics, the tirasemtiv trial. That's launched and going. There's a couple that are trying to get their funding in order. There's some stem cells that are being discussed. The ASOs, which is that gene therapy that I just talked about, is ready to launch. Those are the main ones that I have direct contact with or direct knowledge of, and then there's places up and down the state that are participating in others.
So you don't have a top recommendation?
No, I don't. I mean, no. Sorry.
If there's a gap in like your family history, is there a way to test for genetic trait or the gene?
Yeah, it gets complicated, so I'll try to give it to you and see if you can understand it. The genetics, generally you have to, of the 10% that's genetic, we know about 65% of the patients we can identify the mutation. So you have to identify it in the patient who's symptomatic, because then you can potentially apply it to family members. But if somebody else in the family had it and you want to know, you're asking about yourself, like would you get yourself tested?
Yeah, so if you don't know in your family history there's like a blank spot, could you just get a test on yourself to see if you have that gene to say it's familial?
You could, but it's not going to be very meaningful, because if it's positive, it's positive. Then you do know that you're at risk. But if it's negative, you don't know that you're not at risk, because you don't know what the gene is that was in the family to see whether or not you have it or not, if that makes sense. In other words, 35% of the genetics, we don't know what the gene is. So if the family member had that gene and we can't test for it because we don't know what it is, when you get your own test and it's negative, it's meaningless, because you don't know what to test for.
We have a question from the internet, and then we can take one more question from the audience here at the consortium. The question from the internet is, please describe the difference in a certified center versus a non-certified center.
Okay. The ALS Association, in its advocacy for patients trying to get high-quality standardization, has designated a couple of different levels of ALS care. One is the highest level is the ALS Center of Excellence. And to qualify for that, you have to have a multidisciplinary team. You'll hear from our multidisciplinary team. You have to have research. You have to go through a certifying process, and it's quite rigorous. And we worked really hard to get our certification. But one of the components is that we had an active research program. For places that may not have an active research program but want to do high-quality care, you can become what's called an ALS clinic. And so there you don't have maybe the full spectrum, but you've got the team and you've got the clinic and you've got the motivation. And so that's the second level. And as far as I know, those are the two main designations that the ALS Association grants.
Are all patients clinically diagnosed with ALS tested for the genetics portion? And if so, what is determined, or what is the determining factor to test them for that?
Okay, fair question is about the genetic testing. It's in flux, so we debate. At this meeting, we had a whole big discussion about should patients get tested or not if they're not at risk with, if you're familial, if it's in the family, then of course you can proceed to the testing because then you try to identify the gene. So that's, I think, pretty straightforward. The question is, but the sporadic patients who don't have a family history, should they be gene tested or not? And you'll get different biases, and that those opinions are changing as we go through because we're getting used to it. The party line would be you don't get tested because we don't know what to do with the results. If they're negative, it doesn't mean anything. It's expensive, and we don't have a treatment anyway. The newer view of that is that, yes, we should test. We can learn more, or maybe get DNA samples into research and be more liberal about testing. So those are kind of the discussions that we're having as whether to test or not. If there's reason, if there's a remote family history, if somebody had dementia or somebody might have had ALS, if there's reasons, I generally tend to get the test. If I can come up with a reason, I like to do the testing if I can. The one problem with the testing is the insurance companies balk. And then you have to then engender this big, long discussion with an insurance company. Well, can it be justified? And that's a more complicated battle because it can get very expensive, tens of thousands of dollars, and they may not, or they may want justification for it, and then you get into sort of this appeal process. So that's the practicalities of it. Gets more complicated, but those are the pros and cons.
We'd like to thank Dr. Ravits for opening our Ask the Experts today with a big round of applause. Dr. Ravits will be back later this afternoon during our research portion, and so we're going to transition now into our multidisciplinary panel. But while we are doing that, we are going to actually make some adjustments because we've had some more people come, and we want to give them a chance to come into the room. Thank you.
Thank you all very much, and enjoy my team here. They're awesome, and I think they'll have some great things to tell you.
Check 1 2. Check 1 2. Check 1 2. 1 2 1 2. Check check. Check 1 2. That's great. Thank you.
Thank you, everyone, for working with us in that little chair shuffle. I would like to introduce right now Susie Morrell, who's the nurse coordinator for the clinic, and she's going to talk about inside the ALS clinic.
Thanks. Hello, my name is Susie, and thank you for coming, and welcome to sunny San Diego, I'm just going to give a short synopsis of what we have at the ALS clinic. We're a multidisciplinary clinic, and we also, and what does that mean? We have the multidiscipline team here that you're going to be hearing from. Also, we're celebrating our first annual certification of Center of Excellence. So that was a big deal. As Dr. Ravits said, we worked hard for it, and a whole team, all our team here. I talk with my hands, so forgive me. So let me just give you a little bit of the ALS clinic. And you use this, right? Oh, it's not working. Okay. I'm going to have to talk with the PowerPoints, without PowerPoints. And our ALS clinic is a multidisciplinary clinic, which I entered the wonderful world of bifocal, so excuse me here. It's not working. That's okay. That's all right. And it's a comprehensive program, which is, we have the San Diego most comprehensive care program for the patients with ALS. And our clinic consists of a speech pathologist, our research coordinator, our registered dietitian, occupational therapist, physical therapist, social worker, myself, registered nurse, and Dr. Ravits. It's a comprehensive clinic. It lasts 2 to 3 hours, so we tell you to be prepared for that. We also wanted to talk to you, I wanted to talk to you a little bit ahead in how to register to attend our clinic. You call, is it now working? Hi. Okay, thank you. Sorry. How to register to attend our multidisciplinary clinic. You will be calling, I wish we had it, it's a 1-800 number. It is on our website. And so in order for us to have the website to register, and you would register at 1-800-92, let's see, 1-800-926-8273. And that the new patients will register and will be issued a medical record number. That same number will also talk to you about insurance issues, what are accepted at UCSD. Once you get you're registered, you will be getting issued a medical record number. Once you get that medical record number, you'll be calling 619-543-5300, and you'll be talking to our good friend and co-worker, Carolyn Beguera, in the back here, and she will help you and assist you in getting an appointment with us. But there are some things that need to be addressed before you get issued an appointment with us. You need to have a referral from your neurologist and also from your primary doctor. You'll also have to have his recent notes given from the doctor, and if applicable, if you're on a HMO or an insurance outside of the UCSD network, such as Scripps, Sharp, Kaiser, you need to get an authorization. It's very important, or we can't schedule you an appointment. You'll have to pay out of pocket, and we don't want that to happen to you. We also need to have recent EMGs, nerve conduction tests, recent labs, and a recent MRI of the brain and the spine so that the doctors can go over it with you for your visit. Once you get that, we issue you a nice a packet, an introduction packet. Now is it working? Oh, go, cool. So how do you go? Here we go. You get issued an introduction packet, and what it has there is it's a description of our cohorts here. Also, it has the directions to our clinic and tips on how to maximize your visit, and a copy of business cards of Dr. Ravits, Deborah Ways, our social worker, and myself. So it's 2.5 hours to 3 hours, very comprehensive. Keith, our associate, our ALS associate, he gives a packet or a binder so that you can help in organizing your visit to maximize your visit. And last but not least, I just want to tell you, navigating through these complex waters can be difficult, but we're here to help you. So if you have any questions, don't hesitate to give us a call. And I also want to tell you how lucky and how proud I am of my co-workers. They are compassionate, and they are a great group to work with. Thank you. Let me introduce you to Sahana. Thank you. So now this young man did, I don't know, you have to.
No, it's right here.
Super too, the cube that's here.
So that's not.
It's working?
Mm-mm. Oh.
It's a little slow.
So is it this
Yeah.
button?
Try clicking X.
Okay. All right. I'll try with that. Hi, everyone. Thank you for coming here today. My name is Sahana, and I'm part of the ALS clinical research team here at UCSD. Myself and my colleague, Ivy Cast, who unfortunately couldn't make it today, we're project coordinators, a part of the team. So our role is to really help you navigate through the clinical research mediums that you encounter. So if you see a trial or study that you're interested in, then we can help provide you with information about those trials. We also manage the clinical trials that we offer at UCSD, so we would be the ones walking you through the patient appointments associated with those trials. So what I wanted to do today is I wanted to just give you a brief overview of what clinical research is and how it relates to ALS, because a lot of times the terminology can get a little bit complex. So the first thing I wanted to talk about is that ALS clinical research is kind of divided into two separate categories. The first category is biomarker studies. So a biomarker is an indicator of the severity or presence of a specific disease. And with ALS, unfortunately, because there's so little that we know about it, these studies are extremely important because they can potentially help doctors diagnose ALS earlier. So they're really important for the future of ALS in terms of figuring out a treatment. So if you are interested in a study like this, what would typically happen is you would come into our office and we would collect a set of biological samples from you. So we would take some samples of your blood, potentially your urine. We would do a skin biopsy. We might do a lumbar puncture. And these procedures are done in conjunction with a set of other assessments. So we might give you some respiratory assessments. We might do some muscle strength testing. And we would do that at each appointment that you would come in at to assess the progress of the disease. The next category of clinical research is obviously the clinical trials. And this is really looking at at candidate drugs or treatments and looking at how safe they are and how well they work to counteract the effects of the disease. And I know this is something that most people are really excited about. So there's a few different stages of clinical trials. Before it can even be tested on humans, the drug or treatment has to be assessed within the laboratory. So that's the time that we're going to look at its effect on animals, typically mice. The next stage of clinical trials is phase 1, and this is the first time that it would be tested in humans. And so at this point, again, what we're really trying to assess is the safety of the drug or the treatment. So are there any adverse effects that patients with ALS are experiencing by taking this? Once it passes through a phase 1 clinical trial, it then moves on to be categorized as a phase 2 clinical trial. And during this phase, what we're looking at is the specifics of the drug. So how often should you take the drug, what the dosage should be, how should you take it? Should you take it orally or should it be injected? So these types of questions are what we answer at that point. Typically, the sample size for this is about 100 patients or so. Once it passes through phase 2, then it moves to a phase 3 clinical trial, and this is the last and final phase. So at phase 3, this is the point in time where we're trying to assess what the effect of the drug is on the disease, on ALS. Is it having a positive effect? Is it actually helping to relieve any symptoms or reverse those symptoms? So this is the last and final phase. So typically the sample size is much larger. It's about 1,000 patients or more that we'll try to enroll. And if the results from this are positive and statistically significant, then it can move on to be FDA approved and open for the general public to try out. So here at UCSD, we offer both clinical trials and biomarker studies, and I would be happy to go into the specifics of what they are. I have my contact information on this slide, and so if you want to know the specifics about them, I can reach out to you and we can talk about them one-on-one. The last thing I wanted to leave you guys with is a few excellent resources that we typically give to our patients. The first one I think Dr. Ravits had mentioned earlier is clinicaltrials.gov. It's not specific to ALS, but any study that you hear about will be on this website. So you would be able to find an overview of what the trial is about and also who to contact if you want to partake in the study itself. The next one is the NEALS Clinical Research 101. It's basically kind of what I shared with you today. It just gives you an overview of what clinical research is in the ALS world, and it also answers some frequently asked questions associated with it. The next resource it's a very unique resource. It's called ALS Untangled, and it helps review any off-label or alternative treatments that you might hear about. So things that haven't necessarily been FDA approved yet, and if you heard about something that's happening internationally and you want to know more about it, the side effects, this is a great place to go for that. And the last one is Patients Like Me. This is a forum really for ALS patients to help compare the treatments that they've experienced. So if you want to find somebody who is experiencing similar symptoms to you and you want to see what they're trying, you can go to this website, find someone who looks almost exactly like you on paper, and see if they tried something that worked for them and what the side effects are. So this is a really great way to compare different treatments that are out there. So that's it. I'm here after this to answer any questions you might have. Thank you again so much. The next person I'm going to introduce is Lindsey Schaefer. She's our speech pathologist.
There we go. That works. Hi, everybody. I'm Lindsey Schaefer. I'm one of the speech pathologists. One of the things that I wanted to talk about a little bit is swallowing and communication. They play a very important role. One of the key terms that you may hear is dysphagia, and that's difficulty swallowing, and that can affect the oral phase, the pharyngeal phase, and even the esophageal phase of swallowing. One of the most important things about that is that we want to prevent aspiration, which is when food or liquid may enter the lungs, because we want to make sure that lung function is really good, obviously. And so we do that in many different ways, and we do that with swallow evaluations. It may be done just in a clinic, or there's other diagnostic studies that we do. One of those is a video swallow study or a modified barium swallow study. And there's also a flexible endoscopic exam of swallow function that allows us to really evaluate the swallow function and see if there's any strategies or modifications that we can give to you to help you with what may be difficult. And the other part of that aspect of, aside from aspiration, is also swallow function can be more challenging, and endurance can be a challenge. And so one of that ways that we work with that is also working with our clinical dietitians and making sure that we get kind of the most bang for your buck, and making sure that if there's modifications that need to be made to textures, that we provide those, education, and different strategies, which I've listed some up there. The other aspect that we work with is communication. There can be changes in speech function, voice function, and even cognition. One of the other big words that you might hear is dysarthria, and that's changes in how the respiratory system can affect the voice, or how the muscles change in the lips and tongue, and how speech changes with that. Communication is really important. It's a huge part of a quality of life for everyone, to communicate their wants and their needs. And so we look at how can we make that as easy as possible for you. And that may be as simple as just some speech strategies, as well as also some higher tech or low tech augmentative alternative communication devices. And there's a wide range, and everybody has different needs and what works for them. And so part of our role in that is assessment and seeing how we can help everybody through that process and what works best for you through that process. There's some other things out there. I know some people are into and really want to preserve their own voice if they have that ability to, and that's working with voice banking as well. And then there's also can be some cognitive changes, and part of that is also just helping through that process and strategies and how to be as functional as possible at home. So next up, I'm going to introduce Kaylee Mackay, our registered dietitian.
Hi everyone, good afternoon. I'm Kaylee Mackay. I'm the dietitian at our clinic. And my role in the clinic is to ensure that patients are receiving adequate nutrition. And this is important because nutrition is the foundation of good health. It's the foundation for preserving our body's highest potential for function, our highest potential for muscle strength and daily endurance. When we're not able to get enough nutrition, we develop something called malnutrition. And one of the biggest predictors of malnutrition is weight loss. And we know that malnutrition and significant weight loss is associated with shortened survival. So to combat malnutrition and weight loss, we recommend a high-calorie diet and no restrictions. So there are many studies going on trying to determine, is this a high-carbohydrate diet? Is this high-fat? Is this high-protein? But the common theme in all of these studies is high. So we want high calories. And the reason we recommend no restrictions is when we take something, a food group, out of our diet, that means we're losing calories. And so we need to be very diligent about replacing anything we might take out of the diet. There are also currently no studies that are showing a particular benefit in restricting any food group. And so for this reason, we just say, let's be as liberal with the diet as possible and make sure we're getting as much calories as possible. So some of my favorite tips for a high-calorie diet is just eating as frequently as possible. So instead of thinking about 3 big meals throughout the day, we think about eating every 3 to 4 hours, or perhaps 6 small meals a day. But I want to remind everyone that every spoonful counts. So if that meal is a spoonful of peanut butter, a spoonful of whatever, that counts. That'll add up throughout the day. And so also think about maximizing our beverages. So making those beverages high calorie and nutrient dense. Blending these high-calorie smoothies at home is great, but if you like convenience, we have some ready-made shakes available at almost every grocery store, every pharmacy, things like Ensure, Boost. And then there's also store-bought equivalents that are usually at a reduced cost. I want to mention Carnation Instant Breakfast is available as well. And we want to avoid low-sugar or low-fat diet products. And finally, let's make every bite count. So that means adding sauces, gravies, butters, oils to as many foods as possible. There are some challenges. Do we like that? Okay. There are some challenges that are unique to the ALS population with maintaining adequate nutrition. First and foremost, as discussed, some swallowing and chewing difficulties can develop, so we collaborate with speech pathology to determine what are the textures that meet your individual needs to make swallowing easier, and then modifying liquids, perhaps using thickeners to make them easier to swallow. And then there can be fatigue or weakness, so we collaborate with occupational physical therapy for feeding assistive devices. We consider, let's move the majority of our calories to times of the day where we feel least fatigued. And then, again, there is a higher metabolism associated in the ALS population, so we combat that with a high-calorie diet. And there are some studies showing that compared to the general population, metabolism is 15% higher than we would predict. And if any of these challenges become too burdensome, we have an alternative. We can consider placing a feeding tube. And sometimes we call this a PEG tube. And this is just a tube that connects from outside directly into our stomach. And so it allows nutrition. It can allow fluids and or medications to be put directly into the stomach. If you choose to use this tube for nutrition, we can prescribe a tube feeding formula that the doctor and myself collaborate to meet your individual nutrition needs. There are some advantages to consider in feeding tubes. They can help us maintain weight, reduce your fatigue from eating, using that energy to do other things during your day. It reduces the time you have to spend at meals, and it avoids the risk of choking. And I would like to mention that one of the common misconceptions about feeding tubes is once it's placed, we can no longer eat. And that's not true. We can use the feeding tube to supplement your oral diet as long as that's safe for swallowing. And that's the conclusion of my presentation. I think we might be opening it up to questions at this time. Thank you.
So now we're going to have a few minutes of questions and answers for the full panel. So please raise your hand and we will bring you the microphone, and then we ask for your patience while we bring the microphone to the presenter.
Kaylee, are there any nutritional supplements available that are not sweet? Like liquid supplements that are not sweet?
Yeah.
So we're looking for nutrition supplements that are not so sweet. That's the biggest complaint I get, absolutely. Yes, there are some supplements that are less sweet. For example, I know of Orgain. Orgain and Complete is a tube feeding formula that can be available to take orally as well. But to reduce the sweetness, you could consider mixing with whole milk or using that as a base, your sweet product as a base, and then in the blender and adding other things to it, for example, avocados, oils, just to reduce that sweetness.
A question about the clinical trials. On the phase 3, my question is with the issue of ALS, there's a lot of, the big problem is time. I mean, you don't want to spend years researching when people need the treatment now, before it's too late. So some studies are on fast track. Can you give me and the audience a sense of what it means to be on the fast track versus on a regular track? Because on a phase 3, if you have several years of studies, my God, you know. I mean, the whole population of the United States may be wiped out ALS-wise before the study is done.
No, yeah, that's definitely one of the most frustrating issues with clinical trials is that they do take a lot of time because we want to make sure that they're as safe as possible for patients to trial. You can fast track certain drugs, and the way that works is you have to have enough people to petition it and the FDA to approve that it gets fast tracked, and that just depends on a number of different factors about the drugs and the trials that are done. So typically some of you may have heard of it, but the GM604 was one of the drugs that people tried to fast track to the FDA. And at this point, I think the last news about it is that it has been fast tracked. But that was based on the results of the phase 1 clinical trial because they were positive. So depending on what the treatment is and the drug is, if there's enough momentum behind it, then it can be fast tracked.
I have a question of the same
Yes.
person. I've read that there's a law that's passed in a number of states called the Right to Try law, as different from the Right to Die law.
Yes.
AB, I think it was 509, was vetoed by the governor in this state. Have you got any thoughts on the Right to Try law? It seems to be somewhat contrary to what you and Dr. Ravits have said. My understanding is that once you've passed phase 1 clinical trials, the safety phase, that why shouldn't we have a right to try something that hasn't proven itself efficacy-wise?
Yeah. So I think that we're here to help you make the best decision that you can and offer you any resource upon that. By no means are we going to tell you that you shouldn't try a drug. I think that it is in our interest to just make sure that you have all of the knowledge that you need before you make that decision. But ultimately, it is up to you if you want to try it. I think the hesitation on our part is that we just don't want you to try something that is going to give you an adverse effect or isn't going to help you and just waste your time. And that's why that there are so many different stages of these clinical trials, is to make sure that they are effective and efficient for you.
Kind of a follow-up to that would be, is there a way to get into trials that if we decided that we'd like to, in other states where the Right to Try law has passed, Arizona, for example, and the stem cell research, I've read some very positive effects on that. Is there a way that you could help us get into a, not so much a trial, or maybe it's called a trial, maybe it's just called a...
to test it, yeah.
Yeah, and you know, I think there's an argument against double-blind studies as well, because a percentage of the people who are getting it won't be getting any of the medication. And it seems like there's a good argument for trying it. I mean, what have we got to lose at this point?
Right.
If there's something that may help, may not, but why not try it?
Yeah. So in reference to your question about how we can help you try something, that would be something that we would have a discussion with you and your doctor to figure out if it would be an appropriate course of action for you to take, and if it's something that you really want to do. We have done that with patients before, where we've been able to give them a drug that they've wanted to try. But that would be a more individualized personal conversation that we would have with you and your doctor specifically. Does that answer all of your questions?
Hi, this question is for Lindsey. Could you speak to therapies that you use in the clinic for helping people with articulation and other speech issues?
Yeah, so the clinic is more of a consultative basis, so we would refer them for outpatient therapy services, which are free or available for anyone. And so what that entails is usually an evaluation, and then we look at each individual. So it looks at, you know, if they're having difficulties with their respiratory function, specifically with their voice, then we would address on how to best use your speech for that. So sometimes it might be some over-articulation strategies, or kind of reducing what it is that you want to say by making sure that you're getting the key points out if it's a really labor-intensive process. And it's a very patient-dependent process. Typically, we don't give necessarily exercises for that. We look at making sure that you're using what you have to the best of your ability.
Yes, I'm a clinician, and I was diagnosed 2 years ago. And the issue that I found with clinical trials, I applied for 35, and then the 35 had one response to tell me that they were too busy to respond. I don't know if anyone else has experienced this, but obviously if you can't get into a trial, it leaves very little hope. Is there any effort made into making this process more accountable?
Yeah, absolutely. So I can't speak for who it was that you contacted before about that, but I know I would like to think that here at UCSD, we are really easy to access. And if you are interested in something, typically we'll respond to you within that day or the next day about something you're interested in. In terms of if you're interested in trials that we offer at UCSD, the process, as Dr. Ravits mentioned, is pretty quick. We can get you in for a screening for that trial within the week after you email us. So if you are interested in something, I know in the slides before I did have my contact information out there, and definitely I would work as quick as I can to make sure that this process is as easy for you as it can be.
I'm going to put that to a test.
Okay. Hold me to it.
My question is in regards to voice banking. So if we wanted to do the voice banking, how do you go about getting started with that?
There's some different options out there. Sometimes there's computer programs that you can do, and there's also there's ones that take your voice and synthesize it for you. That's not going to be a free program, but there's also just recording on your own computer or some different programs, applications that you can record things into. And then they recommend recording, names of family members, certain phrases that are said, different things like that.
So you're speaking as an app that you would have on your iPad, you can just download it and then you would start recording your voice?
It's more on the computer rather probably than an app.
Okay.
There's different options out there.
And how do you find out about them?
I have resources for them, so if you want to, I can give you my card and I can get your email and email those to you.
Perfect. Okay.
Mm-hmm.
Thanks.
Follow on clinical trials. I got some exciting news, but I didn't hear from you guys about this, but you may want to look at that, at what I'm going to say. At Mass General and the Mayo Clinic, a company called Brain Cell Therapeutics is testing Neuron, which is a stem cell therapy that I went to Vegas to the International Stem Cell Symposium, which had people from all over the world giving the results of the studies. And in the case of Neuron, the results for phase 1 and 2 are in the 80th percentile of slowing down the disease, and in one case, totally bringing it back. I'm surprised that you guys are not linked up with Mass General and the Mayo Clinic with this study, because it's on phase 3 and it's on fast track.
Right.
So
I think one of the challenges with clinical trials, and especially sponsoring a clinical trial, is that there are so many exciting clinical trials out there. And right now we are working to become a site for many exciting new ones coming out. That is definitely something that I think Dr. Ravits would be interested in sponsoring, but we do have about 4 or 5 studies that we're trying to start up right now. So that's not to close the doors off and say in the future that we won't at all, because it's definitely something I think he'd be excited about. But as I said, we are in the process of starting up 4 or 5 different projects and studies going on.
No, and I didn't mean for you to do the same thing that Mass General
Right.
and Mayo are doing. It's just that what is funny to me is that the communication is not there. I expected to hear from Neuron here.
Right.
Because he's in the Mayo Clinic and in Mass General, and he's on phase 3 now. And
Yeah.
he's on fast track. And when he talked about anything, nothing was mentioned about Neuron.
Yeah, and I think that each region, what I've found is each region kind of has their different focuses on what they're excited about. And so as you heard Dr. Ravits mention, I think he's really interested at this time in gene therapy and a bunch of other different areas. And again, it's not to say that the neuron trial isn't something that we wouldn't bring on. I just think that it's not at the forefront of what we think has the most ability to progress at this time.
Right here. I'm a veteran, and I have a doctor at Balboa, and I have a doctor at the VA, and both doctors work with your clinic. I saw Dr. Ravits last week. Do they share the information? Because I seem to be doing the same thing 2 and 3 times.
Hello. So what happens with that is we are in connection. We should. Sometimes it's not happening, and what we need to do is, could you please give me a call, and we'll get that coordinated so that we do have it, so that it is in your medical files, so that Dr. Ravits has access to it. And you're absolutely right. Unfortunately, the VA and Balboa, we don't have that communication yet, that internet, the electronic medical records done.
But the doctor, I think it's Apides.
Apides, yeah.
He is related with you guys, right?
Jolla Apides is a physician from Balboa, and he works in Balboa. He's a Navy he works for a Navy hospital.
Yes,
So
okay. What he said, I was told he
can communicate with
communicates
us.
with you guys.
Yes, we can
Okay.
get that coordinated. Go ahead.
I just wanted to say we're going to take 2 more questions from the audience and 1 from the internet, and then we're going to be taking a short break.
I have a question in regards to nutrition. You mentioned the high-calorie diet.
Mm-hmm.
Do you have a list for us that we can look to find what are those high-calorie issues? And the other part of the question would be, in the event that you get a high-calorie diet, with a person with ALS that is immobile or in a chair, confined to a chair, how we're going to burn those calories also would we run into the problem of diabetes?
Wonderful questions. So the first question is, do we have resources for a high-calorie diet? I'd be happy to provide those to you. A website that I particularly enjoy is the University of Virginia Health System. They have a list of high-calorie diet tips. I'd be happy to meet with you during the break and provide you a more direct link to that. And then your second question is, you're curious as to why, when you're confined to a wheelchair, you're burning so many more calories. Is that correct? How can you burn those calories? So that's a great question, and it's currently under research. What we do know is when we test the metabolic rates, when we study those metabolic rates of ALS patients, they are elevated. And so we are trying to figure out exactly your question, why is that? But one of the things we know is when you have increased work of breathing, that burns calories. So the poorer your respiratory status, the more calories you're going to burn just by breathing. So I don't have the exact answer. We're working on that right now.
What is your approach to the caregiver?
Oh, Lisa, I'm sorry.
Did you hear that?
Yeah, so what is our approach to the caregiver?
Yes, or do you have any specific?
Well, we do. We have, we encourage the caregivers to attend the multidisciplinary clinic to help them and in aiding them, because as our social worker will be mentioning, this disease does not just affect the patients that are afflicted with it, but it's a family. It's a unit diagnosis, and it affects our caregivers. So we encourage them to come and help them in aiding them on how to cope with this, because it is a daunting situation.
Thank you so much. We actually have a question from the internet, which will be our last question for the morning, and it's a comment and a question. The comment first was, I want to thank all of the presenters for making themselves available, and I appreciate you and the organization for doing this and your many kind responses. Keep up the good work. We're grateful. Will these slides be available to us after? And I can go ahead and answer that, and the answer is yes. As will the video. The video will be a part of YouTube as soon as we're done web streaming today. So I'd like to thank everyone for their presentations this morning. Let's give them a big round of applause. We're going to take a short 10-minute break. 10 minutes and 5 minutes to get everyone back in the room, Giovanna. Oh, yeah. So we're going to take a short break. Please go help yourself to some refreshments, and when you come back, we will have the second half of our clinical panel. Thank you.
Well, yeah, he drinks beer. I do drink beer.
Well, that's high calorie. My doctor told me I get in his gut if I stop beer.
But how important is the liquid?
Yeah, we definitely don't want to be dehydrated.
Yeah, that's the thing.
Hydration, hydration is important for energy.
Yeah, just sipping.
You can work, absolutely, taking many sips throughout the day, gentle reminders, but something that's been effective for people is get a big water bottle, like a big 1 liter or 2 liter, or keep it tally system if you have the time. Like I finished 1 today, I finished 2, and when you're done, you mark it, so you're just keeping track and getting to that goal. About 2 liters, if it's clear, shake. Orange, that shake, Regenerative.
Okay, thank you very much.
This is something you do. This is something you put in recipes. Another doctor, nothing to do with ALS, said my wife was losing weight, which is about she is. And so she had a whole stack of coupons for $3 off bottles of Boost Plus.
Ooh, I got the same thing.
Yeah.
From somebody else? Or you need the
I
coupons?
got them from the ALS clinic.
Okay, maybe for insured.
That's it, sure.
Insure, is it Insure Plus? About 300 and some calorie bottles. That's great. You should just start stacking. When you come to a meeting like this, you should just be clogging them out.
That's a great idea. Yeah, that's a great idea. It just involves some coordination with Nestle makes Boost. Abbott makes Insure. So if you want to go to those websites, you can offer coupons right on there. I like your idea. I'd rather
The
just
problem is they give you one. My doctor gave me a quarter inch of them. Here's you start drinking these things, you want 3 or 4 a day.
I know, right? It's really good. I have to stop myself from taking my
And they're all too
husband's.
sweet. I'm trying to find somebody to give me something called a meat smoothie. Yeah, I keep talking to my wife. I don't like smoothies, but if you don't want a sweet smoothie, let me whip out put some milk and some chicken breast. You know, just a meat smoothie. That would be sweet. You know, you calories. So experiment on chicken and
There's a talk. I'll keep that in mind. Hi. Hey, did you say that
My husband has the PEG too. Okay. And right now he's only putting liquid vitamins through. Okay. But I think we are this close or ready to have something else like supplement his nutrition this way.
Right.
You say there's pre-made stuff. Okay. And does it have to be plunged down, or can it be gravity induced or whatever?
Many different methods. Those are true. So yes, you can use syringe or you can use gravity.
Okay.
They almost always start you on syringe because it's the most convenient. It gets done quick.
Can we, when we come to the next ALS clinic, can we just bring, the thing that snaps into the tube, and you can show us how to do this?
I am not
Or
sure
is this-
in that area. There's a home health agency that you can talk to Susie about arranging this. But when you receive the tube, hopefully there was a coordination with a home health or a home infusion agency.
Just for a period of time, and that was basically just to say, okay, this is how you do it, you just, let gravity, go down. So, but we've never, so that's all we've been doing, but for something thicker that's going to produce some
an actual tube feeding formula.
Right, we don't know where.
Okay, let's get Susie.
Susie to do that.
Let's get Susie. We get back in touch with your home agency. Say new development. We want to do something different.
Right.
Let's have someone.
And then they'll bring out whatever the mixture is.
Yes.
Is that how they do
so
it?
They, So we have to, on our end, we can help ensure that there is an order. So we need a tube feeding prescription.
Okay. All right.
So who is your one?
I think it's not for another. But I'll talk to Susie.
Yeah.
Thanks.
Well, I didn't
It's diabetes and drugs. I said like high he drinks diet soda.
The next one up, I guess. Just over button to get on to the next slide.
Oh, she wanted me to.
What?
She wanted me to pull this up in the interim.
Right. But I mean, once I come up.
Right,
like,
you would
just-
escape out of this and go back into PowerPoint if you want to.
Oh, okay.
Yeah, this is a PDF.
So just escape, go into the PowerPoint?
Yeah, and there's my assistant Clint will probably be up here.
Oh, okay.
To help you out. Are your PowerPoints in with the other ones?
Yeah, it's all in
Great.
one. Yeah.
Great.
One long shot.
Sir, here's your PowerPoints are just right down here.
Okay, cool.
Yeah.
So just pull it up and then view slide.
Yep. Yep.
All right.
See the slide I sent you?
This is what I have.
I sent a slide that was different, so.
Oh, I did not get that.
It would have, like, did you just check in the last?
Just checked.
Let me redo it.
Okay. Was it? You sent me something from Google Drive. Is
Yes,
that?
that's it.
Okay, that's going to be another challenge. Okay, sure. Let me see if I can pull that up. Let me just pull this. Momentarily. Oh no, this laptop is just slower than dirt.
Understood. So yeah, it's a slide.
Okay.
Hi. Good to see you too.
No, I just meant, so you're.
My dad's appetite's gone down. I don't know if that's like common or anything, but like how would you help that? Because he just doesn't seem to feel like he's like yesterday, like 2 minutes. He didn't even want to play. He's like trying to get him that kind of thing. No. Yeah.
get it done 3 times a day.
Yeah. Yeah, and as far as smoothies go, like, we tried a few different like fruits and stuff, but like strawberries and even sometimes bananas, like the seeds, it bothers him. Like it gets caught in his throat, he's then having a problem with excess secretion, so like that's really bad for somebody that's caught in his throat. So like do you know if like we've been doing like Ensure, Muscle Milk, or like other like supplements like that like high calorie shots of smoothie type something you can drink, but like variety would be nice for him. Like we need different flavors, but at the same time, it's like, I don't know if you know of any other like things to make smoothies out of that like seeds or small bits of stuff.
Right. Okay. So,
Do you have enough space now for you guys to stand up? Okay, just want to make sure.
Yeah. Okay. Yeah, you gave that when we were there last time.
Thank you.
just to get us like.
That's weird. Oh well, that's fine.
Here we go?
Yeah.
Great. Okay. Awesome.
Yeah.
Good stuff.
God.
Oh, no.
Okay.
Thank every universal deity for you.
Thank you so much. Trying to make it run smoother the second half.
Okay, yeah, I haven't been doing that over at Consortium, but yeah, we'll do that for sure. Yeah, and then so like if you were to make like a big smoothie, just like have a nurse on it.
Check 1 2. Check 1 2.
Sure. Yeah. Exactly. Okay. Yeah, we'll have a help. I know. Yeah. Like I said, it's a loss of. Yeah, he's like not the. Yeah, peanut butter's just not his thing. Yeah, I mean maybe if it's mixed up with other stuff, he's just never been a fan.
So again, you just hit escape.
Okay. We'll see.
Yeah, that's it. Thank you so much.
So as far as like the nutty, like trying to find maybe like some type
exactly.
of
Exactly.
That's you know you touched on it. Okay. Yeah, are those over the counter or do I have to get prescribed? Okay. That's fine. Yeah. Okay, so that's kind of normal though. Like, okay. Yeah. Yeah. Well, yeah. Yeah. Well, thank you very much.
So protein does contribute to calories. So when you think about food contributing protein, anything that also is going to be high in protein. So fish, pork, beef. Yeah, you can absolutely do those. The vegetarian sources of protein are those bars, nuts and seeds. Yes, so exactly. Yeah, so protein is also calories. Yeah. I would be careful about supplements. Whoever you talk to, the doctor, and we know that we can get the protein from our food. We know that it doesn't have side effects. So it's kind of maybe spend that money on food, or yeah. Right? The power of advertising, yeah, and a lot of regulations.
I was told to come out over out here so they can ask her questions.
Oh.
We're all looking for it. There's some people that have some questions.
I can't do it.
I just mean go with what you. That's what I would do.
Hi, everyone. We're going to get started with session number 2, so if you don't mind taking your seats, that would be wonderful.
You look good in that purse. You know what? It looks, don't you think it blends in well with it? I'm sorry. Oh, wait. Did you? I would do exactly if you're here. For this meeting, I would do it. I would never. Well, that's what we were kind of thinking, is maybe a train. Maybe a train, that's what we were thinking about. Right. Right.
Are you able to plug in your chair and charge it yourself? I didn't know. That's how long you were. Right there.
I know. You got the same issue I do.
Put it on charge overnight or something. Once a week or all the time.
You know what, I put a big sign on the chair that said, these are my
Gel cell technology.
No, they don't. They don't. Yeah. You know what? You know,
You got a nice
I
smart
think
charger.
it's
Some
gonna
of the
come down
chargers
to
are real dumb and can overcharge.
the plane is corrupt. And the train, with all the washouts and stuff going on, they'll stop you on the bus. And you can't get on.
No, Jennifer.
They said there's a lot that I can learn there about.
No, we're all
I have to get going. I hope everyone was able to enjoy the refreshments from Bella Vista. I want to give them a special shout out for some wonderful catering for us today. Food's been delicious, so thank you to our caterer. They've done a great job. So we want to move along in the program. Right now we have, we're going to continue with the multidisciplinary care with ALS, and I would like to introduce Gardner Faulkner with UCSD to discuss respiratory care in ALS. So thank you very much.
Hi, good afternoon. Let me just pull up presentation real quick here. Oh, that was close. All right. Hi. Thanks for coming back this afternoon. My name is Garner Faulkner. I'm the respiratory care practitioner at UC San Diego. I'm going to go over a lot of information. Probably have way too much information to go over for just 5 minutes, but got a lot of information that I just wanted to kind of briefly touch on. Won't go into great detail, but just kind of briefly kind of touch on a lot of stuff that we do in clinic initially with patients that come in that we see, and then also on routine visits, and then things that we think about when we're talking about respiratory function and respiratory care in the ALS population. So probably one of the biggest things that we do is pulmonary function testing. You'll hear that a lot with ALS is pulmonary function. We do serial pulmonary functions, meaning that we do them every time. We do initial, when patients first come in initially into clinic, we typically do 3 sets of different pulmonary function tests, and then we'll do them upon each clinic visit. And the whole basis of that is to trend how someone's pulmonary function is doing. Some of the main pulmonary functions that we do, there's several different types that you can perform. The main one is what's called a forced vital capacity, FVC. This is basically after someone takes their deepest breath in and then blows out all the air they possibly can. It's that amount of volume of air that they can forcefully exhale. And that's why we call it forced vital capacity. It's typically expressed in a percent based on other people, same age, same height, same sex. And it's, like I said, usually a percent. A lot of times people want to know what is normal. What's normal? I always say your baseline is your first one. So when you first come into clinic, that's going to be your baseline. So it may be 80%, it may be 70%, maybe 60%, but that's going to be your baseline. And that's the biggest thing that I tell people to focus on is where does it start and then where is it trending from there? We get it often sitting or in a seated position and then also laying down or supine. The reason being is often when people lay down, not having help from the diaphragm, the vital capacity can drop. So that's often why we'll check the vital capacity in the laying down position as well. We also do what's called a peak cough flow. It's basically testing the expiratory muscles and how well air is forced out. We also do what's called a maximal inspiratory pressure. It's a negative pressure. It's that little round meter there. It's in a negative pressure, so negative 50, negative 60. Usually around negative 60 is typically where we start, and then we trend where it goes from there. The other thing we look at is kind of a respiratory assessment. So we basically assess, and this comes in tune too when I was saying earlier about the pulmonary functions that we get. I often tell patients not to focus so much on the numbers, but because your numbers will be something that we're going to look at in trend and that we do pay attention to. But the biggest thing is how do you feel in your symptoms? So this is something I look at and assess, but it also something I educate patients on to keep an eye out and look for as well. So do you become short of breath? Do you become short of breath with activity? I do, I just did. But if you're just sitting there resting, do you get short of breath as well? So when those things start to pop up and change, those are clinically significant, and you should tell your respiratory therapist, you should tell your doctor, your neurologist about those things. Also, sleep quality. Do you become short of breath when you lay down? That phenomenon I was talking about with the diaphragm when you lay down, not getting help from gravity, that's usually one of the first times when we see breathing difficulties show up is at night. So when you lay down at night, do you get short of breath? Are you needing pillows to stack up to sleep at night? 3, 4, 5, 6, 7 pillows to sleep? Are you getting sleepiness in the morning, headaches first thing in the morning? Also, the other thing we look at, because of that forced expiratory cough, as that gets weakened, are you having trouble coughing, clearing out mucus, secretions? Food, are you choking on food? Spitting, a lot of times people first notice they are brushing their teeth and they can't spit. They can't spit out the toothpaste, they can't spit out the water, or they have trouble clearing their nose. So that all goes in line with the force to get out stuff. One of the last things I'll kind of leave you with is some of the devices out there that, I know there's a lot of pictures, I like pictures, so a lot of devices out there that we use to help with symptoms and help with quality of life. One of the kind of biggest things that we've seen a lot of good publications and a lot of studies on is what's called non-invasive positive pressure ventilation. It's also called bi-level, BiPAP, not to be confused with CPAP. BiPAP is also just a trade name from a certain company, so a lot of people call it BiPAP, but it's actually bi-level ventilation. It's used to treat respiratory insufficiency. So with ALS, often we get under, as the muscles become weakened, the lungs become under-volumed, and we become what's called atelectatic, and the lungs become smaller and smaller and smaller, and that causes symptoms of shortness of breath and also causes complications such as pneumonia and collection of mucus. The goals of non-invasive positive pressure ventilation is to improve that respiratory insufficiency, to reverse or improve that nocturnal hypoventilation, so to help those symptoms at night and to improve your sleep quality at night. To get better ventilation at night will help you during the day and help you improve your quality of life. It'll recharge your batteries, like I said. I always tell patients if you're kind of going 24/7, you're going to be tired, right? So you got to recharge at night. And if you're not sleeping well at night because you're having to breathe constantly and work hard to breathe, you're going to be tired the next day. So it basically helps kind of recharge your batteries for the next day. We also have, they have different styles and devices, face mask, nasal mask, what's called sip and puff ventilation, a mouthpiece. We also have assisted devices, mechanical assisted cough to help clear out the mucus. So it's basically like a mini vacuum. It pushes air in and sucks it back out. And it helps basically remove out that mucus. Also have what's called a suction device, which is very similar to at the dentist, like the little wand that you put in your mouth and clears out the mucus. Very good for patients with bulbar dysfunction with a lot of constant saliva. And then also it works in conjunction when you're using that cough assist device and it brings out the mucus. It'll help clear out the stuff so it's not pulled in the back of your throat. So I know that was a lot of information. There'll be time for some questions at the end, but I'll leave you next up with Kim. Thank you very much.
Hi, everybody. My name is Kim Bond. I'm an occupational therapist, and I'm also going to be representing my colleague, Melissa Doyle. She's a physical therapist. She was not able to make it today, so I'll be talking about both disciplines. Oops, wrong way. I got it. Occupational therapy, a lot of individuals ask me, what is OT? And specifically what I work with is trying to improve, maintain your ability to perform what we call those activities of daily living. Think about when you woke up this morning, you probably hit the alarm clock 2 or 3 times like I did. Getting out of bed, getting dressed, eating. Oh, I need to bring it down. Okay, I'm sorry. Getting out of bed, eating, being able to get dressed again, being able to bathe, and also doing your toileting skills. That's really what we focus on in occupational therapy. One of the other things that I do, along with the physical therapist, Melissa, is that we help prescribe individual-based programs for exercise to maintain your range of motion, your joint range of motion, to maintain and improve your strength in all 4 of your extremities. I also make recommendations for assistive devices or DME equipment, which may be a bedside commode, a hospital bed, or a Hoyer lift, for example. Other assistive devices that I may specifically work on is devices that help with eating. It may be a simple universal cuff where, let's say, you have some weak hand muscles and you're having a hard time grasping, or it's maybe a mobile arm support that's actually supporting the arm coming up to the mouth to feed yourself. One of the other things that I do is I do all the wheelchair seating assessments for the ALS clinic. So if you notice, there may be a continuum where you might first come into our clinic and maybe you're using a cane, and then things may progress where you maybe need a walker or a wheelchair, or even a scooter or a power wheelchair. And so that's one of the things that I work with you and your family to educate. For physical therapy, again, there's a lot of, we work together, so you may see some duplicate things that we do, which is why this is great, because we're such a multidisciplinary team. We're often communicating with each other and working together to really help the patient and to help the family. Physical therapy really improves gross motor movement, strength and balance for walking, for being able to stand up, for being able to get out of bed. Also with PT, again, just like myself, we prescribe an appropriate exercise programs as well as energy conservation and range of motion guidelines. And again, I want to say that we encourage the patient and the family. This is a learning experience for everyone. And often I may see some people in the clinic and then they come see me one-on-one, and we may have a whole session where we're working on just rolling or working on some use of equipment, for example. So it's definitely a family effort and caregiver effort. Also with physical therapy and also myself, we definitely want to teach fall prevention and educate you on proper body mechanics when you're helping your patient, your family member, maybe stand up or transition from the bed to a wheelchair, for example. We also work with, and I know you're going to talk to Renee from the ALS Association. We talk about equipment, and I know Renee will talk about it more, that they have a big loan closet, so we coordinate efforts together that you may come in to see me so I can train you on how to use a piece of equipment, and then you may see Renee where she actually can deliver it to your house, for example. Other things, too, with physical therapy and also myself is we may recommend an orthosis, for example, what's called an AFO or an ankle-foot orthosis to help stabilize the ankle when you're walking. Or I may fabricate or make a splint for your wrist if, let's say, your wrist is weak and you're having a wrist drop. And this might make you more functional to use your hand to pick up things, to eat. and to do those things that you do every day. Most importantly, we want you to be independent. We know you want to be independent, and we want you to continue to move. And that's our goal, is to teach you and the family how to be independent, how to keep your strength, build your strength, and be able to do everything. Come out here today to do everything that you guys want to do. How's my time? So next I'm going to introduce Debbie Weiss. She's our clinical social worker.
Hi, my name is Debbie Weiss, and as a social worker, I focus on social and emotional, not medical and rehabilitative concerns. Oops, sorry, I didn't give you the slide. With the goal of maintaining or improving quality of life. I do this by trying to empower all of you pals and families through your own inner strengths and knowledge of external resources that we may give you. My first goal at the clinic is to begin to get to know you. I assess for strengths, limitations, support and coping, and address specific concerns you and your family may bring. Initial reactions to the diagnosis from PALS vary, as Dr. Ravits was talking about earlier. I think a big reason for that is the way it's been given, the diagnosis has been given in the first place. But some people may show up feeling pretty adjusted to the diagnosis, where other people may be very anxious or depressed. And I intervene appropriately, making referrals as needed and provide resources that you may request. Losses are common throughout the course of illness. With loss, when first brought up, we talk about predictable stages of grief that come with loss, how these reactions may resurface with other losses, and how all members of a family may experience them at different times. As you all know, ALS is a family disease. You pals and family members come to us during illness reporting positive things in your lives, which we're thrilled to hear about, but also report many challenges. Common challenges are from the pal, for example, who am I as my body changes? And from the caregiver, how do I find time for myself and how do I mobilize others to help me out? All of the family needs to learn how to modify expectations for one another as roles change. You also need to keep communication lines open. In addressing challenges, you may be helped by using successful techniques you tried with past crises. Talking with other pals and their families may add insight. I've listed other challenges on here, but when I went over my slides again, I thought that the challenges that I listed secondarily aren't just important, but I think they're the key ones towards living well with ALS. They include not letting ALS define you, staying in the present, and focusing on spirituality. Spirituality is not necessarily religion, but can be anything which gives your life meaning. I underscore the importance for support to all of you. Family, friends, co-workers, members of congregation of church or synagogue all may make up a support network. Learn how to mobilize all of them. If there isn't a support network, join a support group. A support group can provide not only support, but resources, camaraderie, and a sense of community for others who get it. At the clinic, I pass out a packet containing information and some external resources. We encourage using reputable websites in lieu of Googling to avoid misinformation, especially from those websites offering false promises. Having information not only gives you an overview of the disease and the scientific strides being made, but helps clarify misconceptions, lets you know about things you need to plan for, and what things you may need to make decisions about in the future. I'll go to my next one. Some of the resources from the packet, which are external resources that I include, are www.benefits.gov, which tells you what you qualify for in the way of benefits, SSA.gov, Social Security and Medicare enrollment, the VA, which Robert's going to talk about, has loads of benefits, and the PVA represents them great for us in the clinic. ALS Association provides support, advocacy, equipment, and transportation, as does the MDA Association. Southern Caregiver Resource Center is caregivercenter.org. It's local resources, fact sheets, case management, and some respite for caregivers. 211 San Diego is a 24-hour bilingual social service helpline. SDG&E information, health information, housing, food, etc. are all included in their information bank. and a crisis helpline, last but not least. It's a 24-hour crisis helpline that if you're feeling down or anxious or have a crisis, you can call them. It's 888-724-7240. And I had a couple of quotes to end with. One of them is Michael Okens. He's with Parkinson's disease, but nevertheless, his quote I thought was great. Regardless of your religion or political position, hope is the most powerful weapon you can employ to combat disease. And at the end, I'd like to remind you, don't let ALS define you. Life should not be a journey to the grave with the intention of arriving safely in an attractive and well-preserved body, but rather to skid in sideways, chocolate in one hand, wine in the other, body thoroughly used up, totally worn out, and screaming, woohoo, what a ride. So, I'm sorry, Robert. This is Robert Kamai, and he's going to be doing the next speech from the PVA.
Sure.
As David stated, my name is Robert Kamay. I'm with Paralyzed Veterans of America. I don't normally need a mic, but I will use one anyway. As stated, I'm as on the slide, it says I was captain in the Marine Corps. That is for sure. Next slide, please. Paralyzed veterans actually started after World War II. There was veterans, a couple of veterans at the time were paralyzed, and they were realizing that the VA was not really providing the benefits that they should be receiving, or the other service organizations weren't as knowledgeable on how to, because when you have a paralyzed situation, you have a multitude of things that are going wrong at the same time, and they're not understanding how to work those benefits at one time. So fast forward to today, in 2016, there's 61 offices with 25 spinal cord injury units, and what those are spinal cord, well, now it's spinal cord injury and disease or disorder. I'm not sure which one I prefer, disease or disorder. I don't like to think I have a disorder, but you know, but you have your spinal cord injury, your spinal cord disease or disorder, and then 25 hospitals around the nation. Next slide, please. What PVA provides, we have a multitude of things that we do, especially at the chapter level. They have, I'm sure you've seen the wheelchair games and all that good stuff that they do. They provide support for that to get people to those locations. But the big things that we work on, and that's on the chapter level, but at the benefits level where I work on in Mission Valley, our whole purpose is try to get the VA to get people with ALS the proper benefits that they deserve. And what happened recently, it's actually a couple years ago, they finally thought it was a good idea to increase it to 100% disability, which it is, because they're realizing that at that time it was just 30%, and they were realizing that this is a fast-moving disease, and whenever you try to put in an increase, and by that time, not like I'm saying that's going to happen to anybody here, but as you're putting in an increase and then the veteran doesn't make it for the increase because it's such a fast-moving disease. So they just automatically went to 100%, then authorized the housing grant to go with that, and then just recently they also added the auto grant to go with that. So what the housing grant is, and that you can put that to the next slide as well. The housing grant is what it is it's at this time it's $73,000 to modify your home, to make it handicap accessible for a wheelchair, to make it the doorways at least 36 inches wide. But the most important thing about the housing grant is that they're fixing that bathroom, because that's the most important thing, is the bathroom, to make sure you can shower, you can use the bathroom, and the most important thing about the bathroom is it's big enough so that the wheelchair can rotate with a 5-foot radius. So the big thing about that is the bathroom, and then anything after that is what they want you to, is whatever makes it easier for you. I know in my case, I took out the carpets to make sure I had wood floors, because if you're in a manual chair and you're on carpet, you're not going anywhere. So I think that's a big thing about that. And the housing, the auto grant is a $20,000, well, roughly $20,000 towards the purchase of a modified vehicle so that we can get, in VA terms, the most important thing is just getting you to appointments, but the modification is to, the grant is to help you with the purchase, but the VA pays for the modifications already. So the modifications are around $25,000. The purchase of the grant, or the cost of the amount of the grant is $20,000. So hopefully the out-of-pocket expenses to you is very minimal. So, and then that's it for me. And again, we'll have questions at the end, and I will pass it on to Renee.
Okay, so hi everybody, I'm Renee Buell. As you can see, I'm not Keith Miller. I'm filling in, he was ill today, so forgive my rambling. I prepared briefly before now. I've been with the chapter for just over 10 years. So to kind of briefly and quickly describe what our chapter does, we want to be your problem solvers. We want to work with the community, the clinic being one of those things, to overcome any obstacles you may have and to make your quality of life better. That could include coming out to your home, sitting with you, helping you kind of figure out what maybe some urgent needs are in the home, helping you get to some special events. We do offer our transportation. It's mainly for medical appointments, but from there we go case by case. We never want a family to miss out on a special event because you can't travel to it. An example being, we had a gentleman that wanted to go to a casino for his last hurrah and had no way to get there. So it's outside normal business hours, but we took him anyway. He's not going to get that back. We've taken a gentleman to see his brand new grandson, his first grandson. You can't get that back. So we did take him there to see his grandson. But again, we want to be your problem solvers, and all of that is case by case. So what we want to do is help work with the family to help identify what you need and then where to get it. I know Keith was planning on, and I've gone completely off slides, so he didn't need my help any. So I know Keith was planning on talking about our loan closet specifically, since that is what he does. However, I'm going to go over it briefly just to kind of touch on everything. So the main thing for our loan closet is to provide equipment. We do work with the clinic one-on-one to try to make sure that we do give you equipment that you're going to be safe, not get hurt, and it's the best that you can get. We do see the needs where people maybe can't afford a copay. That would be when you can utilize our loan closet to borrow the equipment for as long as you need it. We encourage you to get your own through insurance so that it is the best for you. But sometimes it's hard to achieve for a family financially. So we try to fill in as best we can. And with that, I say we're working with the clinic. An example is when you get a power chair. We have a plethora of power chairs. But there are certain features that Kim could recommend that would be better for that person to be comfortable and to be able to use it. So we try to work one-on-one with her to customize what we've got in-house to get as close as we can to what you would have had ordered anyway. And then I touched on transportation. We do have support groups. In the program, there is a list of our support groups. We've got them all planned for the whole year. We're hoping that all stays, but it could change here and there. But I do want to make sure that I open up and ask that you guys provide tons of feedback for us as a chapter. We're constantly wanting to go over the programs that we offer to make sure that what we're offering is being utilized and it's helping. But if you have a need, we want to address that as well to see if there's a program that we can start. One of the programs just recently that we started, and Keith was a huge factor in this as well, we've just started a caregiver education program. We're doing it quarterly where people can come in, you get a little exposure on common types of equipment and then some safe lifting techniques. We're going to expand that hopefully to start including CPR, first aid, and several other things to try to get caregivers very confident and very comfortable with providing care to your pals. And then beyond that, again, case by case. We want to be your problem solvers. We don't want to hear a family sitting on the phone for 3 hours trying to find a caregiver. Let us help you find some companies and caregivers. We want to do that background searching on the phone. So just give us a call. That's what we're here for. And then I think I've rattled on enough, so I'll cut it off. And I guess then we're opening now for question and answers. Is that right? Thank you.
I have a question of Debbie. I find the ALS Association really to be helpful with many of the things that you described, but there's another group that hasn't been mentioned today that can also be helpful, and Debbie knows a lot about that group. Would it be appropriate, Debbie, to talk about the muscular dystrophy ALS chapter?
Yeah, I think it's very appropriate because I think at the end of the day, what we want is as many services as we can get for as many people that can come. So the third Saturday of every month, MDA gives a caregivers and patient support group. The way it works is that both or either can come to the group, and when you get there, you split up. There are 2 therapists there. I'm one of them. David Moss is the other, and each group has a way of just opening up and saying exactly what they feel without having to worry about hurting the other person's feelings. And it's been very successful, and I think it's great that we have both because we have all the information side coming from your end, and the MDA is totally just people talking amongst each other, like a therapy group. So it's good to have both, and so thanks for asking, Rusty, because...
How would people find out more about that?
Yeah, the only way, all you have to do is call the MDA, or Muscular Dystrophy Association, and they'll give you more information on it. I know it's kind of an interim right now because apparently we're changing locations. So this month is the last month in Mira Mesa, from what I understand. I'm not quite sure, but calling them is your best deal. And I'm sorry I don't have the number with me. But it's right on the website, so thanks.
Tying in with what this gentleman was saying, does the San Diego chapter not have any support groups scheduled regularly, so that people don't have to necessarily go through the MDA? Thank you.
They have, what they have, what?
I said you can feel that. I mean.
Okay, yeah. They have, as I said, from what I understand, their groups are, they're for caregivers and patients, but it is more of an informational thing. It's a way of meeting each other, but it's not a support group format. So, and it's good to belong to both of them anyway, because you have a lot of the same perks in both of them, so.
There is a list in the program of what we've got planned.
Once a month, yeah. Oh, say, I guess I didn't tell you, they meet once a month. Oh, okay.
I just have a question about support groups. We live down in Oceanside, up in Oceanside, and would be interested in a support group. It's hard for us to get around. We do have a electric chair, but we don't have a way to transport it. We don't have a van. And it's just would be nice to have that support or to get to know other people in our area that are going through the same thing. And how do we start support groups in other areas other than San Diego?
I'm actually not sure, to be real honest with you. I do know there's also one in Riverside. I'm not asking you to go to Riverside, but I know the social worker there, and she would probably be a great source of information too. Maybe I can ask her and get her some information, see what we can do about that, because that's probably a really good idea, just to figure out how to put it someplace where it isn't.
Hi, sorry, my name is Jared Mullins. I'm with the Orange County chapter of the ALS Association. I'm over here speaking, sorry. They put me in the nosebleeds. So I don't know, maybe I'm sensing something that could be an incorrect tone, but every organization that supports ALS families are all doing this because we want the best for those families. And neither MDA or the ALS Association San Diego chapter, Golden West chapter, Orange County chapter, or our national organization wants you to be separate and force yourself to choose one opportunity over another. If you have questions regarding MDA in Orange County, we will gladly give you the information because we work alongside them. And I know that they do the same down here in San Diego, and I know that they do the same up in San Francisco and in Fresno and in Sacramento, and we'll just focus on the state of California for that. But if you call and you receive an answer that you feel is not what you were looking for, then ask another person. Because ultimately, for all of us working within this organization, it is our charge and our mission to support you. If you don't feel that support, then we haven't done our job right. So in regards to MDA up at UCI, they have a wonderful support group meeting, and they do it differently than our chapter. We put on 2 different support group meetings. They put on 1 separate support group meeting. In Fresno, they try a support group meeting that's done via a teleconference for those families that can't get there. And so we recognize that there are a lot of needs that are going unmet, but we want to do what we can to meet all those needs, just as Renee said. So please know that every organization wants the best for all of our families. And specifically in Orange County, we work alongside ALS TDI, MDA, Guardian Angels of ALS, and Trish's Angels. And every one of them has incredible resources for families, not just in Orange County, but nationwide.
Great, thanks.
And I wanted to add one quick comment to that. We do know that there are some people that can't travel down from North County into San Diego. And just like this is being webcast today live as we speak, that is one of my goals that I've had at the chapter for quite some time that's actually going to be realized soon. I want to be able to webcast in case you can't travel down from North County, then at least you can log in and see what's going on in that support group. And that way, if it's live cast like this is going on, you can still participate, ask questions and so forth, so that you can, quote unquote, go to the support group without having to go to the support group. So that's one of the things, because our chapter is fairly small staff-wise, for us, I think that's going to be our better option. It's not a perfect solution, but it's the best that we've got right now, and I really hope that it will include people that are up in North County, or at least make them feel more included than maybe they do now.
My wife's neurologist tells us that he has 5 or 6 ALS patients, and we were having difficulty getting all the way into San Bernardino at Loma Linda for support groups, so we started one in Murrieta. And this month will be their 2nd meeting, just by asking the question, why don't we have one here with your patients concentrating here? But I have a question now for respiratory therapy. On one of your slides, you showed one of the goals to be the slowing the rate of FVC decline. What is that?
Yes, I apologize I didn't go over it. Like I said, I put a lot of information on it. So the forced vital capacity is one of those measurements that we get in ALS clinic. It's that total amount of air that you can forcefully exhale out after a maximal inhalation. And with ALS, it's also kind of a generic term for lung function. So you'll hear someone's lung function is 75%, is 60%. It's something that we trend, and there's been a lot of studies recently done showing non-invasive ventilation will actually slow that decline. Without the use of non-invasive ventilation, that decline happens much more rapidly and goes down much more quickly.
We face a rather unique situation in that lung cancer has resulted in a lobectomy for her. How would this impact your testing?
That may affect as well. So one thing that we look at, so ALS in general, in the otherwise healthy patient shouldn't affect lung function other than the muscles that affect the function of the lung. If you have another multi-system like COPD, asthma, lung cancer, that will affect the lung function, and it will affect the progression of which things occur, as well as maybe the starting points as well. So that's something that we take a look at too, is the medical background and the history. So if it's just ALS to start with, that's one thing. But then if we have other things, like I said, like chronic obstructive pulmonary disease, asthma, something like cancer where you've had lobectomy, so you have lung reduction already because you only have part of your lung, that's a factor that we need to take into account as well, and be a little more aggressive with some of the therapies that we can do. Thank you.
I just had a question for you, Robert, and you guys as a panel. You guys are awesome. I just want to say that real quick. I'm from Hawaii, and you guys are like a well-oiled machine over here, so I really appreciate, and I've taken tons of notes, and everything has been very helpful, so I appreciate that. Thank you. Robert, do you, I work with military veterans in Hawaii, and I am positive they don't know anything about what you do. Do you have any type of affiliation with Hawaii military? And
actually, our Los Angeles office is the one that represents Hawaii.
Okay.
So all our offices are CONUS on the mainland, but Hawaii is covered by Los Angeles, and Alaska is covered by Seattle.
And is there a website or something like that I can go to for? Oh, right on. Okay, thank you very much.
My husband has a question. He's always had sinus conditions before this ALS thing came up. And he would wake up, he sleeps fine, but he wakes up congested. And even after the ALS, it's the same thing. We've tried raising the mattress, the head of the mattress a little bit. It doesn't seem to help. Do you have any thoughts on that?
For me?
Yeah, for you. I'm picking on you.
I figured it was geared towards me. I was going to let Kim answer it, see what she had to think about it. No, that's actually, I feel for you. First off, I've had 3 sinus surgeries myself, so, but that is a common issue. So as, especially as ALS affects the expiratory force, so kind of 2 component muscles that we look at when we talk about respiratory or ventilation is the breathing in, pulling air in, and then forcing air out. Forcing air out is, with clearing the mucus and secretion, but it's also up in the sinuses. And as that becomes more difficult, you get more problems with the sinus cavities too. So one thing I could recommend is ensuring that you talk with your doctor, and also maybe follow up with an ENT physician to make sure there's not something there with with chronic sinusitis. There may be some bacteria that's being treated. Also, if it's something where you are having difficulty clearing out mucus, that cough assist that I discussed. So not only is it good to help evacuate and remove secretions from the lungs, it's a mask that covers your mouth and nose, pushes air in, and it sucks it back out. Well, if it's covering the nose, it's going to suck out the nose as well. So I tell a lot of patients that it actually kind of is beneficial in 2 ways. It sucks out from the lungs, but it also clears out the sinuses. So a lot of people, when they start that, they're like, oh my gosh, my sinuses are clear.
I can breathe.
Yeah, I can breathe. Also, those suction devices, they have an oral adapter, but they also have a sinu adapter that you can stick up in the nose, right in the tip, and it can help drain. But I think the biggest, probably primary suggestion would be to talk to your physician and make sure you see like maybe a specialist to make sure all that's being treated, that there's some sinus rinses you can do, some steroid nasal sprays to make sure, all the passages are open and stuff, so infection's not brewing in there. But then the second part is those aids to help evacuate some of that stuff.
What's interesting with him is when he stands up, clears up,
Really? Yeah. So.
which is a good thing.
Yeah, exactly. So some of that, kind of preliminary treating during the day can help at night. Things like propping up and stuff help because then it helps it from draining and stuff. But maybe some of the daytime extra treatments may help with the nocturnal symptoms as well.
Exactly.
Hope that helps answer.
We'll give it a shot. Thank
Okay.
you.
Good.
The positive pressure machine, is that as effective if you use it during the day? I can't sleep with it at night. It's like there is no sleep.
Yeah, that's a good question. I feel like I'm popular today. Anybody else? That's a really good question. I always, and if I had a little bit more time on my slides, I would have kind of discussed positive pressure ventilation. It sounds wonderful, right? It sounds great until you actually put it on. Any of us that have actually worn it, and I've worn it myself, maybe I need to back up, can tell you that if you can tolerate it, it's amazing. If you can't tolerate it, it's not so great. I always tell people it's kind of a double-edged sword. It's meant to benefit you and improve your quality of life, improve your sleep quality. If you're wrestling with it all night, keeping you up all night, is it really doing any good? Maybe not. So if you're having difficulty with it, having difficulty sleeping with it, then maybe that dual mode. So the nice thing about the non-invasive positive pressure ventilation, it's 2 pressures, but the non-invasive portion of it, we also usually do dual settings. So we sometimes will do nocturnal settings, but then we'll also have daytime settings. And that's when we can do the mouthpiece ventilation. You can do the mouthpiece ventilation. It's got a little angled mouthpiece that you just put in your mouth, sip on it. It's called sip and puff. You just sip and puff on it. Gives you a kind of big breath in, and it kind of fills your lungs up. So I think that sometimes is beneficial if you are having difficulty wearing it at night. I think you get the best and most benefit if you can wear it at night. Some tricks are, wearing it during the day when you're watching TV, trying to acclimate to it. But if not, maybe try those dual settings where you can do the mouthpiece ventilation during the day, kind of sip and puff, get those bigger breaths in, and see if that helps. So, hope that answers.
Can the yoga abdominal breathing help support your breathing attempts?
Yeah, so I think things like yoga, Tai Chi, breathing exercises, a lot of questions I get in clinic are, before the equipment, before I start doing all this, especially early on in the disease process, maybe before lung function starts to decline, or if it's not declining at all, what are things I can do supplementally outside of all this equipment? Things like yoga, deep breathing helps. It helps re-expand the lungs. When you re-expand the lungs, that atelectasis, the kind of shriveling up of the lungs, goes away, and you don't get, like I said, when you get that kind of atelectasis and stuff, then you start getting that phenomenon where you get a feeling of shortness of breath. You get feeling of shortness of breath. You get panicked. You get anxious. But then also you become susceptible to things like pneumonia and stuff, because as the lungs get collapsed, stuff and secretions get trapped down there. And then if you throw in there, you have a weakened force and cough, you can't get that stuff out there. Then it kind of lays in there and pools and breeds infection. So taking deep breaths is one of the easiest things you can do. A lot of people have probably been in the hospital and been given that little plastic thing that you breathe into. All that is to give you a visual to take a big deep breath in. On it, it gives a little kind of a description of what kind of volume you should achieve, and basically you want to try to just achieve a big breath. Doing something like that, a couple times a day, 10 breaths is good. Just sitting there taking a big deep breath every now and again. holding your breath for a few seconds, letting it out. If you can't take a big deep breath in, taking little breaths in. 3 breaths, hold it, let it out. We call it breath stacking. There's also called glossopharyngeal breathing, frog breathing, as I call it, little gulps of breath. Looks like a frog, right? And then blowing it out. That takes a little practice to do because you have to use your tongue, soft palate. If you have bulbar dysfunction, it may be difficult. But those are little things that you can do to help with volume expansion. So I probably talked way more than you wanted to hear.
No, thank you.
Sure.
Since you're there.
Oh, yeah. Kim? Yeah.
On your slide, you had a number, trying to achieve a certain number and an abbreviation, which you did not explain.
Oh, yes, my apologies. So if I can go back to it here, maybe. So it was the peak, if I remember correctly, it was the peak cough flow. And whenever you're looking at that expiratory force, there we go. So the mechanical assisted cough. So when we look at those 3 different values, one of the ones we look at is called peak cough flow. And it's basically a quick blast of air. A lot of people, if anyone's ever had asthma, it's very similar to a peak flow meter. And you basically blow real quick, real fast. And it's simulating basically a cough. That flow in healthy... In healthy people, maybe 400, 500, 600, 700. There's been a lot of studies out there. Dr. Bach from Rutgers University in New Jersey has done a lot of recent information looking at what value does, when it hits a certain value, where are we looking at dysfunction with cough? And it's right around 270. And I've seen in clinic from taking care of patients, it's pretty right on. Right when you start getting below 300, actually, people start having symptoms of cough dysfunction. So right when it starts dropping below 300, 270, 280, patients are actually complaining of difficulties clearing mucus, clearing secretions. If I do that measurement and it's around 270, 280, I can know without even asking. I'm like, you're having difficulty coughing. You're having difficulty clearing mucus. Oh, yeah, I sit there and hack and cough and cough. Once you go below 270, usually you cannot bring out the mucus. And that's whenever the mechanical cough assist comes in very beneficial because it will actually help clear out the mucus then. Yeah. Okay, thanks.
Hello.
Hi.
What I'm going to say doesn't mean that I don't appreciate all of you, but I came here to see the light at the end of the tunnel. But all you said was how to manage the darkness. In other words, the diagnosis, the etiology of the disease of ALS, and the treatment for it was what I was looking for. And I'm sure that if you had one of the patient talking about his or her experience through last few years of his disease, it would have been a lot more helpful to say that we all have heard all this, and the only thing that we are looking for is the treatment, the way to recognize the reason why the ALS comes on. And I tell you about all the numbers that you give about respiratory function test is that for you is a number that you tell me that my forced vital capacity dropped from 70 to 60. But for me is another few nights not to be able to sleep because I recognize that my disease is getting worse and worse and worse. You are not going to increase it from 60 to 70 again. The only thing you give me is more trouble, more worry, And I don't know why Dr. Ravits, who is the neurologist, has only 5 minutes to talk about the disease. And the rest that are just managing the darkness in the tunnel, they are all taking time, and every patient has heard this for years. You don't think that you have changed anything from 2 years ago to today to tell us about the respiration. I don't think the occupational therapy has said anything different from 3 years ago up to now. The only thing that we are looking for is the reason, the effort that is put on to founding the treatment, or giving us a hope for the future, near future. 2 years ago, I heard that there is explosion of research in ALS. And today, again, exactly the same statement Dr. Ravits made. I'm hoping that at 5 o'clock, the gentleman who came here for the stem cell, whatever he's going to do with it, give us some hope. But so far, I really think that I will leave this place empty-handed.
I just wanted to quickly comment to say that Dr. Ravits actually is coming back in the second half, the third part of our session. And the goal of today is to present a really broad spectrum of information. We understand that it is not one size fits all. Dr. Ravits will be back in our final session, which will be starting in about 20 minutes. And so these would be, good questions to ask at that time. So I just wanted to restate that he was brief in the beginning because we knew he was going to be coming back. We do have time for 4 more questions here in the audience, and we do have 3 on the internet that are waiting.
My question is for Kim. One of the things that you stated that you work on is mobility. But being confined to a chair, one of the problems that I have is, one of our greatest problems is transition. Transition from the chair to a car, to the to go to the restroom, to go to the shower. What equipment are you recommending? And the one that I want to focus on is from a wheelchair or power chair to a passenger side of the car, not necessarily driving. Is there equipment for that?
You need to come back and see me for therapy.
Okay.
Yes, there is, especially because we know each other. Again, everyone has, it's individual, but I will say for this, transition from a wheelchair to a passenger car to a bed to a toilet, for example, you can use what's called a sliding board, which is basically a bridge that for you, because I know you and I can say this, is that you can do a lateral slide or even kind of a sit pivot from the chair to get into the passenger side of the car. So, and great question. In therapy, come back, see me. That's what you want to work on. Hey, Kim, I want to be able to get into the passenger side of my car. And we'll work on that. We'll work on that with your manual chair. Power chair, you have more benefit because the seat to floor height is a little bit little taller. And of course, I know maybe the seat elevator. That will help as well. And then we can talk more, but I think that's a good question. But yeah, that would be very helpful for you.
One word on the slides that wasn't touched on or expanded on is lymphedema.
Yes, actually, my other hat, I am a lymphedema therapist. So because of, if you're in a we're used to moving around and walking around and getting from one place to another. If you are using a chair, for example, and you're seated in the chair most of the day, if you have a power chair, the benefits of that is those seating functions where you can elevate those legs up, you can tilt back to help with circulation. Some of you came because you don't have transportation for your power chair, so you're using your manual chair. So you've been sitting here pretty much all day, and I'm sure some of you may have some swelling. Elevation as much as possible, sometimes using compression stockings, and I can easily talk to any of you outside of this. But that's the big thing. Moving around as best you can. If you can do even a heel slide or an ankle pump, it is really is the best thing to help manage that circulation and the swelling.
We have time for 2 more questions here in the audience.
Question number 1 from the internet. Can you talk about the benefits of strength training when you have ALS?
That's a great question. We want to maintain motion. We want to make sure that our joints move nice and easy. Range of motion is one of the things we teach. Also, to answer the question with strength training, we want to maintain our strength. We want to try to improve our strength. The research isn't great out there with exercise in ALS, but there's a psychological benefit. There is a benefit that we want to keep moving. We want you to keep moving. Even doing the diaphragmatic exercises, that's exercise. Range of motion, strength training. Again, it's very individual. And that's one of the things that we look at in therapy. If you come into whether it's physical therapy or occupational therapy, we look at what your strengths are, and then we build from there. So I think it's important to continue to be active, continue to exercise. And again, like I said, everyone's different. And again, that would be a good reason to come to see a physical therapist or an occupational therapist.
Thank you. We have another question from the internet. Can you please talk about the neurology? Can you please talk about the American Academy of Neurology's practice parameters for ALS and multidisciplinary care? What does that mean?
That's a Susie question. I think that's a Dr. Ravits question, actually.
So we have one final question from the internet. Can you speak about Medicare and ALS?
Yeah, I can. If you're under 65 and you want Medicare, the route that you take is to go through Social Security disability, enroll in that, and then that gets you through to Medicare. Not everybody is going to qualify. It'll depend on whether you've paid into Social Security, living in the United States. How many credits you earned in your work beforehand, and also if you're working at all, you can only make there's a cap at which you can't sign on. If is that pretty much? Oh, I'm sorry, yeah, the most important part. Thanks, Susie. The most important part is to let people know from the very beginning of enrolling that you were an ALS, that you have ALS. With other people, there's a 2-year wait for getting into Medicare once getting SSDI, but for ALS patients, it's 5 months. So it's really imperative that you tell from the very beginning that this is your issue. So.
And we have one last question from the internet, which has to do with the loan closet. How does a person make a request for equipment from the loan closet?
So for the loan closet, pretty much all they have to do is just call into the chapter. they can ask to speak to either myself or Keith Miller. And then see, at that point, there's a discussion that starts. For us, again, we try to work with the clinic to make sure that that equipment is adequate, that it's safe. But the very first step is just to call into our chapter and see what we have available. One thing I do want to point out with that equipment, getting it around the county can be difficult. So we recognize that, and we do help and deliver some equipment as well as loan it out.
Thank you very much to our panelists. Let's give them a round of applause. And a big round of applause to all of you and all of you watching on the internet. This has been a pretty die-hard group to... Now we're going to take our last break. Please plan to be back in your seats in 20 minutes, and we will start our final panel on research developments.
Yeah, that's what you need.
We can see it. Right, right. So yeah, we can see what we've got available, but I know we do have some adaptations to the Super Bowl. But I want to say we've got some things that can go overhead that has its own legs that supports itself. That'll come over, but I'll check. But I'll let you know.
You're talking about lifting?
Well, no, it's trapeze. That you hang down for yourself. Try to help sit up.
Oh, but that's not the same structure as the one where you crank it. What did you call your name? Yes, how did you get here?
Oh, my own.
I was hoping Keith would be here. I was going to give him back a wheelchair.
Check one, check 1 2, check 1 2, check 1 2. If you get really close to it, sometimes it can. Yeah. Yeah. You had the right idea. Oh, okay. Sure.
Well, we have another thing.
Oh, the PowerPoint? Sure, absolutely.
Power chair next week. She has a stroller type thing. We only have used this on a couple of special occasions.
Okay.
This one right here? Are you speaking first?
No, I don't think so.
Okay, so hopefully my assistant Clint will be up here to help, but if not, it's right here on the desktop.
Okay.
And you, yes, here, let me eject it for you. And you can just double click on it to open it.
Thank you.
Yes.
Thinking about my next wheelchair. I was able to
and again, we can bring it out too.
But having it so right. But
I'm going to call you as the contact, so I'll start there.
Check 1 2, check 1 2.
And we have offered several who said, hey, we'll talk to Seth, just give our number. We've never heard anything more about it. Right. You know, So that's, I'm just, and I can tell you when I called the first time 5 years ago, I wanted to talk to someone who's in the same situation. I wanted to know what this stuff about for me personally is I wanted to know what it looked like and how do I grab a deal with this? And if this situation, where do I go? How do I get there? So that's what's in the organization. And I can say this because we do that in the and that's one of the, yes, I do. And that's one of the things that I think draws that. I can't talk for the other side, but for us, as caregivers, my husband keeps choking on this. And someone say, well, we did this, or, hey, my husband can't stand anymore, what kind of a lift training is this? We're able to share the information. We're not, I mean, I don't know. That's something you guys like. I wish you guys were working on this. That's kind of what I think that for a long time, we did exactly what and it was kind of like we asked exactly. So
Have you got any slides? Well, she wanted. I don't really need any because I'm only going to go like 5 minutes. But she wanted some for the.
Are you Clive?
Yes. Hi.
They asked me to help deliver your PowerPoint.
Oh, okay. Yeah.
So we can just USB is right there. Okay.
I've only got one slide. So. Oh, it's a. You better do it.
I know, yes. You know, I'm like trying to find a way to do it. Just to sit there thoroughly, yeah, and make sure that it's
And we'll probably just copy it, to the desktop would be great.
Yeah. I have to cut it back, so I just got to take out some stuff.
My apologies, the laptop is a little bit slow, so sometimes if you just give it a minute, it
Oh,
does
okay.
figure things out. But it looks like
No
it didn't
problem.
take too long for yours. Some of the other people had really big photos in their
Uh-huh.
presentations, and it was a little bit slow.
Yeah, we gotta have somebody out there. We need to because we don't. I didn't really know this.
Okay, that's it. I've only got one slide. I'll save that, shall I?
Yes.
Where's the save?
I think it's right there.
Oh, yeah. Okay, and then I can close that.
Great. Thank you, sir. If you need it, it should be on desktop. Just double click. Thank you. Oh, this is a neat one.
Maybe the one right at the top, or right at the bottom. Yes, there it is. Great. Super, thank you.
Thank you so much. So
Oh,
we'll
here we
be.
are again. Next
Nice job there.
Oh, thank you, sir.
All right, glad it worked out.
So if you need, it's just right on the desktop, and you just double click to open it. Yeah.
Do you know if someone's sitting here?
No, I don't. Just a bag. We can put this underneath.
So I have a presentation for, sorry. Hi.
You're going to use your own laptop?
I'm gonna use
That's
my own
fine.
laptop.
So you want to load yours?
Yeah.
Okay.
I'll show you which one it is on
Great.
there.
You have the same USB as the other presenter?
Okay.
I do not want to format.
No.
It does not look like it is readable. Is it perhaps from a Macintosh?
It's from a Mac, yeah.
I can't, unfortunately.
No.
We could perhaps try to get it to another drive. I have a Macintosh in the back.
Let's see, how else can we transfer it?
He has a Mac, and he's maybe going near when you're going.
Are you going to plug your Mac in? Yeah.
He has a Macintosh phone.
We're going to take off right after. Catch a flight.
Are you going first or?
I think I'm going first. You're going last, right? I'm going.
So let me see if I can transfer for you. I'll try my best. Yeah. As a Mac. Yeah. If you want to email it to me, that would be fine. Oh, Sorry about Come on. Check 1, 2.
She doesn't make the music. She says, "Oh, I know we need to bring him over. I just gotta have the time." No, but don't because she tells me I need to have the come over here because it's I know that it's just a matter of we'll set up an appointment and go inside and modify the house. And it doesn't matter that you know. Yeah, you give me a phone. And then you tell us it's going to happen so that, oh, she can't even, it's just a matter of she can make a decision. It's a good thing. It's a good thing that she's there.
Check 1, 2.
Is that right? You can't just verbally say, hey, I'm the medical and I can't do this for myself? I started to actually, and I, right, that sounds like what you. No, I totally understand.
I think if everyone who's out in the other room could start to come back in, and then we'll go ahead and get started.
We've had a little challenge. One of our folks fell, so they're working on that, but I think it's better if we get everyone else back in here.
I know the room is full, so I'm going to sneak in the chair here.
Yes, I think because let's give them some breathing room.
We have just a few more people coming in, I think, right? If we could get people in, so that give Dr. Ravits and folks a little breathing room. Okay. I think we're going to start. Okay. Welcome, everyone, to the second half of the,
Ask the Experts. All of a sudden, my mind went blank. My name is Barb Newhouse, and I have the distinct honor and pleasure of serving as the National President and CEO of the ALS Association. And it is my pleasure to be here with all of you this afternoon. I'm just taking 1 minute just to share with you. I think you're going to be very excited about what you're hearing this afternoon. The last 2 days have been, in the short time that I've been here, which is just over a year and a half, the last 2 days have been extremely powerful and gives me a great deal of hope for where we are headed with for a treatment for ALS, and thus, once we have a treatment, being able to move along to cause and cure. But this is the time that we're in for that treatment portion. The ALS Association has always had as its mission, certainly, cause and cure. I think the only slight modification that we're making is we realize that we urgently must have that treatment first, so that we can change this into more of the chronic illness once we have that treatment. So it's in that vein that I simply say thank you for allowing me to be here with all of you, and it is my distinct pleasure to be able to introduce the chair of the consortium that puts together this entire conference, Clive Svensson, and he's going to share the outcomes from the last 2 days. Thank you.
Okay, thanks very much. So it's fantastic to be here. Thanks to all of you for coming. I'm going to do two things. First, very, very quickly, just update you with some notes that I have here from the meeting. So we just had the most exciting 2 days, I think, and we go to a lot of meetings that we could possibly have had. What we do is every year we collect together all the scientists, all the companies, and all of the industrial and all the clinical centers within the whole of California in one location, and this year it's San Diego. And what we do is we just sit down in this closed room, rather like this, for hour after hour, going through new breakthroughs for ALS and possible therapies and ways that we can understand this disease better and come up with therapies. So I'm very proud to chair this organization. It's been growing. This is our 6th year. Every year it seems to be getting better. This year we had exciting sessions. We actually invited a few outside speakers. One was Avindra Nath, who's from NIH. And some of you may have heard of this story. He's discovered there's an endogenous virus called HERV-K that's activated in some ALS patients. And he discovered this when he treated a patient with AIDS and ALS together. And when he treated him for medications for the AIDS, the ALS disappeared in this one patient. So now they're thinking of retroviral therapies coming along. And he actually has a clinical trial that he's trying in patients that have elevated retrovirus or virus, ALS patients. And that's going ahead right away in NIH. So that's an interesting area. We don't know how widespread that is and how it affects all patients, but it's a brand new area of research that's just opened up. We had a wonderful discussion about that. Genes are coming on. You'll hear more about that maybe later on. And Bob Balow presented some data that, it's possible that sporadic ALS is not run in families, is caused by a different set of maybe 10 genes all acting and interacting together. And so we're starting to understand more about the genetics. Perhaps the most exciting is a number of clinical trials coming up. Cytokinetics, Genentech, Nudexta, Medicine Nova, all just talked about the new trials that are coming up. We're getting better and better at following patients. Now, this is harder for you guys because they're going to be asking you to come in. If you get into a trial now, encourage you to come back to have tests so that we can really follow what's happening in the disease progression and see if the drugs are having an effect. And I think this is a new idea. We're getting better at understanding how the disease progresses, so then we can see if any drugs prevent that or possibly can reverse it. A lot of time spent on the company previously known as ISIS. Believe it or not, they had to change their name. They're now known as Ionis, and one of the chief science officers said that every time he said ISIS, he gets $10. We have to pay him $10 because he has to say Ionis from now on. But Ionis is very exciting because they have a technology that can knock down bad genes in ALS. And they've done that very successfully in a baby model of ALS, if you like. It's a spinal muscular atrophy, and they've shown in patients that actually this technology is remarkable, and it's reducing the death of the motor neurons in these babies, and the babies are living longer. So this is very exciting. There was a stem cell session that I was involved with in our work, where we have a stem cell trial going on at Cedars-Sinai that we're just about to launch, where we're putting stem cells into the spinal cord of patients. Some of you have heard me talk about that before. That we're ready to file that application to the FDA within the next 4 weeks, and we're very excited to get that going. And then we had some inflammation in ALS. There's a lot of inflammation that we know occurs in the brain. Some fantastic talks on how using that inflammation as a marker for the disease and the progression of the disease. So overall, it's been a very exciting meeting. We had also a discussion on the Neuro Collaborative, which is a group of scientists in California that have come together, worked together. It's Don Cleveland, myself, and part of this is and Steve Finkbeiner from UCSF, but we're sort of drawing in the other clinical groups and John Ravits and others into this Neuro Collaborative to understand more about disease. So it's been an incredibly exciting year. And the dinner that we had, last point, is we all discussed the right to try, which is something in California that hasn't been accepted in California. And I think the feeling is this situation is very difficult because of some drugs you might not want to try. Some drugs, believe it or not, could make you worse if it's not done in the correct way. And so I think that's a very complicated area, but we had a good discussion about it. So I'll take any quick questions about the meeting, and then I'll move on to the next speaker. So thanks very much. Any questions? All right. Well, look, have a great evening, and I will hand over to the next speaker, and I'm not sure who is that, Ashkan, who will bring his computer up and plug in. Thanks very much, everybody.
Okay. It's gonna work. Yes, there we go. Okay. Hi, everybody. My name is Ashkan Javaharian. I'm a research scientist at the Gladstone Institute in San Francisco. And just to give you some background, the Gladstone Institute is a research institute, nonprofit research institute that's affiliated with the University of California at San Francisco. And I work in a team with several other people, including Dr. Steve Finkbeiner, who leads some of the work that I'm going to tell you about today. But what I wanted to do today is to just give you a little bit of background about stem cells and what stem cells are and how we use them in the lab to study ALS and other neurodegenerative diseases. And I've been working on ALS for about 6-7 years now. And when people ask me, well, what do you do? And I tell them about ALS. And thanks to the Ice Bucket Challenge, now a lot more people know what ALS is. I usually tell them about my research, and then they ask me whether there are any therapies and what we know about ALS. And my answer is that usually that no, we don't know as much as we want to know, and we don't have an effective therapy yet, but the field is really, really exciting, and we hope to have something really soon. And I just wanted to start out this question that, well, why is it that it's so difficult to study diseases like ALS? And the main reason that it's been so difficult to study these diseases is because we haven't had really good ways of studying ALS or other neurodegenerative diseases in the lab. For one thing, it's really not feasible to take biopsies from people to study how the brain develops, and we have to rely on other systems. Sometimes donated tissue is not really reflective of disease. And using cell lines like HeLa cells that you may have heard about is not really feasible either, because they're not really reflective of what happens in neurons, which are the cells that are affected in ALS and other neurodegenerative diseases. And we've spent a lot of time using animal models, and we have a panel of different animals, including mice and rats and even zebrafish, that mimic features of ALS, but it's still not very similar. And there's been an understanding in the field that we need better disease models to study ALS, and that's where stem cells come in handy, and they've been very, very useful. So what exactly is a stem cell? And if you think about the word stem cell, you can think about the word stem, kind of it makes you think about a tree and roots and how the tree may grow out to become different forms of the plant, maybe a leaf or branches. In this case, it means really a cell that can do two things. One is that it can replicate itself, so it can create another stem cell. And the other thing that it can do is that it can make other cell types. And that includes skin, blood, neurons that are in the brain and in the spinal cord, and those are the cells that are connected that make up the nervous system, fat cells, liver cells. Really, stem cells have the potential to make any of these cells. And the other word that scientists a lot of times use is pluripotent, which really just means, pluri means several, and potent means being able. So it really means that you have a cell that's able to make several other types of cells. So that's a huge, hugely valuable thing. And there are lots of different types of stem cells. You've probably heard about some of these. So there are embryonic stem cells, which can make all cell types in the body. There are fetal stem cells, which can make a few different cell types. And there are also here. So here's an example of an embryo. It's just basically a ball of cells shortly after fertilization. And here's an example of a fetus that's a little bit more developed. And then you've probably heard of adult stem cells, which come from a fully developed adult person, or in case of an animal, an adult animal. And as you go through development, the limitations become more and more. So a stem cell that comes from an adult can't do all the things that a stem cell that comes from an embryo can do. And for that, a lot of people started working on embryonic stem cells, which you probably must have heard several years ago. There was a lot of controversy about, well, destroying embryos. And I just wanted to point out that when scientists talk about embryonic stem cells, they're talking about small balls of cells a few days after fertilization and not fetuses. Those are different. But this research is really not that old. In fact, we can trace this back to 1998, where when Jamie Thompson at University of Wisconsin-Madison developed stem cells from human embryos. Back then, which is not really that long ago, he was able to show that you can take cells from these small balls of cells shortly after fertilization and then grow them in petri dishes in the laboratory, and then basically be able to grow more and more in tons of them. And those cells were able to make lots of different types of cells. They were able to make neurons, muscle cells, skin cells, and other cell types. So it was a huge advancement for the field, because now we had a way of studying cells that we didn't have access to before. And we could study them, we could recreate a disease in a lab in a controlled environment where we can actually test drugs on them. And only a few years later, in 2006, 2007, we had another tremendous breakthrough, and that was when a scientist named Shinya Yamanaka was able to identify only 4 genes that could be turned on in any adult cell that would turn them back in time and turn them into a pluripotent stem cell, or a cell that's acted and behaved very similar to an embryonic stem cell. So that was another huge breakthrough in the world. And here's a picture of Shinya Yamanaka, who won the Nobel Prize for this technology in 2012. He has a lab in Kyoto in Japan, and he has another lab at Gladstone. He actually works upstairs from where I work. Yeah, he's a really humble guy. Actually, I run into him in the elevator sometimes. But by just turning on 4 different genes, he was able to show that you can take a skin cell or a fat cell or a liver cell from an adult individual, grow that into the lab, turn on these 4 genes, and then you can have embryonic stem cells. Then you can technically create an unlimited supply of brain cells or any other cell type from an adult individual. So immediately people started thinking about how to apply this technology. And one of the first things that people started thinking about was how to use this to look at disease and study diseases that we couldn't study before. And of course, neurodegenerative diseases were one of the first diseases that people thought about using. And that's actually around the same time that I started working on ALS, was to be able to use these cells for studying ALS. So the idea here is that we can take cells from ALS patients or healthy individuals, turn those into pluripotent cells, or IPS cells, induced pluripotent stem cells, and then make tons of neurons in the lab, grow those in lots of petri dishes, and then look at the differences. What's so different about a neuron that's sick versus a neuron that comes from a healthy individual? And that is really the way we've been studying ALS in our lab, at least, and several other labs around the world. So instead of the traditional path before, where we would have to create an animal model, study a gene, we now take cells from the patients. We start with the patients, take a skin biopsy, very small one, about 3 millimeters in diameter, and then grow those cells in the lab and reprogram them or turn them into these IPS cells that I told you about. And now the skin cells, after about 2 to 3 weeks, they change their shape and they change their behavior, and they turn into IPS cells that can now be turned into neurons. It takes another 2 months or so after we have IPS cells to make neurons from those. But once we have those IPS cells, we can grow an unlimited supply. So it's really, really advantageous. And then we can take those neurons that come from patients and then test lots of different drugs. And the way we do that is that we grow these neurons in petri dishes that have many, many different wells. So typically several hundred wells or little chambers in them. We grow these neurons in them, and then we add a different drug to each one of those little tiny wells, and then look to see how those neurons live. And this is where it becomes really, really difficult, because in order to be able to actually see those neurons, you need really high-power microscopes. And because this is so much work, it would take many, many people to do this kind of work. And as you know, research is also very expensive, and there aren't that many scientists to do all this work. So what we've done at the Gladstone is to actually invent a system that can automate this process. So we have a system called a robotic microscopy system that we've invented and we've created. And this system can automatically do this type of microscopy that I told you about. So we have a robotic arm that picks up the plate that has the neurons grown in it and then puts it on the microscope. The microscope can go automatically to each one of those little wells that I told you about and take a picture of the neurons as they're growing. And then the other thing that it can do is that it remembers where each of those neurons were. So it comes back to the same one the next day or the next hour, whenever we tell it to. And it takes another picture and then comes back the next day and takes another picture. And with that, we can capture a movie of how the neuron grows or dies or changes its shape. The same way that you could do a time lapse of the sunset here in San Diego. So here's a movie of one of these cultures where the neurons are growing. And if you look carefully, you might be able to notice that there are some cells that are growing. For example, this one, it's growing its processes. This is how neurons look. They have lots of processes because they have to connect with each other and they have to communicate. And there's another one, for example, down here, that's growing, and then all of a sudden it disappears. And that's the cell that's dying. And with this particular system, we've been able to capture which cells live and which cells die. And just to reiterate the point here, here's an example of some of these pictures that we've taken. So there are 2 cells in the left side, which was taken 24 hours. And then 48 hours, the 2 cells are still there. And then, if you can see, at 72 hours, the neuron on the right side dies, and the other one lives. And what we're doing right now is testing a series of different drugs to see which one of these drugs can help allow the cell to survive a little bit longer. And that's a long process, and we have a lot of collaborators. We work with a lot of pharmaceutical companies that have potential drugs that want to get access, and we've opened up this technology to anyone that wants to use it. And we have several different collaborations with academic groups, people who were in the meeting here the last 2 days, and we've had really good progress so far. And the other thing that I wanted to talk about today, I'm just going to touch on for the next few minutes, is the promise of stem cell transplant therapy in ALS. And this is an area that many of you must have heard about. There's a lot of talk about this. And I just wanted to say that at this point, the best way that we're using stem cells is to study the disease and test drugs on them in the laboratory. I think there is a promise of stem cell transplant therapy, but at this point, there has not been any stem cell transplant therapy that's been proven to help ALS patients. Nothing's been approved by the FDA, and that it's very, very important that we do really careful clinical trials where things can be tested in a rigorous way to identify the things that work and things that do not work. And I just wanted to point out that there are a lot of false claims out there promising patients that there could be stem cell transplant therapies that could help patients, but none of those have been proven to show any effect. And we don't even know if they're really injecting stem cells into patients or is it just water? I mean, it's not regulated. So just wanted to caution patients about that. And then finally, I wanted to say that the work that we do is done in a team. There are a lot of people that are involved. It takes, sometimes hundreds of people to actually develop a drug. And I'm really lucky to be working with a lot of great people. I want to especially thank Dr. Steve Finkbeiner at Gladstone, who runs the center that I work with. The people on the left are all the people that are on my team. We collaborate with lots of people in other institutions. And I will also want to mention that we get a lot of funding, especially from the ALS Association. So I want to thank you for that. And other institutes, including NIH, CERM, the Department of Defense, Target ALS, and Toby Carret Center. And thank you. I'll take any questions.
Okay, so you said that the best way for stem cells right now for ALS is to study the disease and to test drugs. What is the next step soon for drugs? Which are the companies that you're working with you towards a drug, or what are the effects on the drug on the patient, just to keep the neuron from dying, or what's the approach?
There are a number of different approaches that we heard about over the last couple of days. I think Clive mentioned some of those. There are several different companies that are working on ALS. There's some small companies, but there are also bigger companies like, for example, Ionis Pharmaceuticals that Clive mentioned, which is also collaborating with Biogen, IDEC. And I think the approach is really to develop drugs that can not only help this neuron survive longer, but also keep their connections and keep functioning better. But at this point, I think there's nothing been proven to show efficacy yet, but there are a number of things that are in the clinical trials. And I think if you go to the ALS Association website, there's a list of drugs that are in clinical trials right now that you can look at.
George would like me to ask, what about the current studies at UMass and Mayo, and the stem cell surgeries in Atlanta and Emory?
Right. The question is, what about the clinical trials with stem cell therapy at UMass, at Emory? I think you're referring to the trials by Neuralstem. Oh, and Brainstorm. Okay. I think those are still ongoing. We don't have any data yet that I've heard of, but I'm sure once the results are more clear, the companies will announce their results. So I don't have any answers yet.
Lucy, do you want to add something to that?
I can just quickly address with Neuralstem. So it can be confusing because there are lots of different trials, and Ashkan didn't mention, but the stem cells can be slightly different in where they come from and where they're going. Neuralstem is a company that has been doing a trial for some time at Emory with Jonathan Glass and Michigan with Eva Feldman, and Nick Boulis is the neurosurgeon. In fact, that technology is educating the stem cell trial that Clive mentioned will be happening. The results of that is that there is at least known safety. So for those that have been in the trial, where the stem cells have been put into the spinal cord at the lumbar level and the cervical level, have shown to be safe. They are progressing to try and do bigger numbers. The most difficult thing, and I'll share some of that in my presentation, is when the effects are very small to know if there is any benefit. So at the moment, with small groups and with the small outcomes, there's been no robust benefit. Brainstorm is the other trial. This is a company in Israel, and they are using mesenchymal stem cells. These are cells that are then taken from the person living with the disease themselves, taken out, modified, and put back in. The thought is that they have some trophic factors that are that the neurons like. The trial is going to be, it's a small study that was done. There will be news about it next week. The bottom line is it's safe in those people that were given it. There is an ongoing study with those same cells at MGH, led by Dr. Sokovitz, at Mayo Clinic, and at UMass. So I think that's what you're also referring to. Can't comment yet. It's all the people that are in the trial have been enrolled, and so they will now be looking at data. So they can't really know until they've analyzed the data. But that study is only sufficiently large enough to see if it's safe. The challenge is really to measure the effects of these, because they clearly so far haven't had a big effect that you can detect something very obviously. I don't want to. A lot of questions will come with my session, so as long as it's more focused on this.
So related to what you're talking about, I went to April of last year. I went to Las Vegas to the International Symposium on Stem Cell Research, and actually Brainstorm released the studies of what happened in Israel. And they were highly publicized and seemed to be fairly effective. So, you know, I don't know if you were able to get those studies, but.
I know those stories, but one has to be very cautious because actually in one case they felt So in one case they highlighted an almost reversal of an ALS case, but actually that person did not have ALS, they had myasthenia gravis. So we have to be very careful when we get these rather overinflated comments and be very measured what it really means. So
What the results that were exposed in the symposium were not about the gentleman and the reversal. It was actual results of the clinical trials in Israel. And so my question is, are you guys, because I talked to the person of Mass General too, who was there, and the results for Mass General are going to be released on March of this year, of the phase 2 of the clinical trials. But the results of the phase 2 of the clinical trials of the Hasadat Center in Israel were already published and have been in the public domain. And they are scientific results. So my question is, why haven't you guys done the link between the results on Israel and the results on Mass General? Because Mass General started the clinical trials based on the preliminary results in Israel.
correct. And so essentially, that's the trial I mentioned. The data has not been released yet. And so Dr. Sokovitz and Dr. Brown, who are working with the teams there, are looking as carefully and doing it as carefully to see the results are still in small groups of people. So it's very difficult to say that they might indicate that there's some hint of some efficacy, and the interpretation of that can be a little bit different from one perspective to another. But at the moment, there isn't a clear major effect from those cells.
I'd like to thank our presenter. Let's give him a round of applause. Dr. Bruin will be back at a later part in the session. We're on to our next presenter.
Do you have a Mac? Yeah, so I can just plug in. I have one. Actually, I have an adapter. It's up there, yeah, it's just.
Oh, it's not opening.
So I was just gonna plug in because this is. Sorry. Sorry about that. Hopefully this works. Oh, okay. Hi, my name is Gretchen Thompson, and I come from the Regenerative Medicine Institute with Clive Svensson at Cedars-Sinai. First, I'm really honored to be here. We have been discussing between scientists and clinicians and people in the industry over the last couple of days, and I think it's pretty obvious, but I think it should be reiterated that the driving force behind everything that we do has to do with the patients and the families and caregivers. So thank you very much for being here. So I'm going to talk about the upper motor neurons in ALS, or my research is really focused on the brain and trying to understand what the brain's role is in initiating
disease onset. So I think we can all agree that a better understanding of disease mechanisms will improve our ability to develop successful therapies. And so if we put it into, if we think about the big picture, we want to know how does ALS start and how do we fix it? So where does it start? When does it start? Why does it start? And so I'm not sure if you need an introduction to the SOD1 rat model, but we use this model because it recapitulates the human condition. It gets paralyzed at about 120 days of age, and it hits disease endpoint whereby it can't right itself in order to feed, so we have to euthanize it. And we use this model to study disease mechanisms and to look at different therapeutic strategies. And so one of the first things I did when I came to the lab, so ALS is not just a one component issue. We have the circuitry from the upper motor neurons to the lower motor neurons in the spinal cord connecting out to the muscle. And so it's not just a one component thing. We need to study the entire circuitry. And so what we first did was we wanted to ask, well, where and when in this rat model does degeneration occur? And so we looked at these different time points throughout the disease progression in this rat. And we looked at the brain, spinal cord, ventral roots, and neuromuscular junctions to see where and when cell death occurs. And so the next few slides are published in this paper, but I wanted to go through them because I think they're important. So what we found was when we look at the spinal cord motor neurons, we actually find that we see cell death in the spinal cord at about 120 days, which is actually pre-symptomatic when you think behaviorally. So if you look at these rats, they look normal at this stage. And this actually precedes in our model the loss of ventral roots and the denervation of neuromuscular junctions. And so if you think about this, and if you're in touch with the whole dying forward, dying back hypothesis, whether it starts in the brain and the upper motor neurons or whether it starts in the muscle and works its way back, I think this is evidence, at least in this model, against the dying back hypothesis because we're seeing early death in the spinal cord that is before the degeneration of muscle in this model. So the next thing we wanted to do was look at the brain because we thought, okay, well, maybe it's the brain that dies even before, the brain cells that die before the spinal motor neurons. But what we actually found was that we don't lose brain cells until disease endpoint. And so if we consider this diagram, there really is no evidence from these anatomical studies that the corticospinal motor neurons in the brain are the first to degenerate. However, although these motor neurons aren't dying, they could be present but dysfunctional. So they don't have to be dying in order to be initiating some kind of disease downstream. And so we went with this hypothesis that the brain is a key component in the origin of ALS. And so if you consider this is a completely hypothetical model. And so if you consider that early on there's brain dysfunction, and this brain dysfunction is causing somehow the death of spinal motor neurons, which eventually causes downstream denervation of the muscle. This is our proposed model. So what we propose to do to test whether that model is true is we wanted to knock down the mutant SOD1 expression in only the brain. So if you think about the rat model that we're using, it's actually a model that is overexpressing a toxic protein everywhere in the rat. And so what if we reduce the toxic expression only in the brain? Are we going to see downstream effects of preventing this dysfunction in the brain? So this is in collaboration with Brian Kaspar. And what we decided to do was we have these tools. We have an AAV9. It's a virus that we use to inject, and it actually knocks down the mutant gene expression. And so what we did was, this is a motor cortex mapping. And so if you consider these regions, is there a pointer? If you consider the regions where it says FL and HL, those regions are actually areas where that area in the motor cortex is innervating downstream the forelimb or the hind limb muscles. So you can map out in the brain which regions you want to target to affect different muscles. And so what we did was we chose 16 injection sites, so 8 on each side. 2, 4, 6, 8, yes. And so when you actually inject this virus as a control with no, without the shRNA, which is the controller of knocking down the mutant SOD1 expression, if you inject just an AAV GFP, you can see that there's no knockdown of mutant SOD1 expression. And D3H5 is an antibody to mutant SOD1 expression. So when we actually put in the shRNA to knock down the mutant SOD1 expression, we see here a really nice knockdown of the expression levels. So what we're doing here is we're reducing the toxic protein in the brain alone. And so what's important here is that we knocked it down in the brain. We also looked in the spinal cord to see whether it was transported somehow and having an effect in the spinal cord, but we actually saw that we were not knocking anything down in the spinal cord. It was very specific to the motor cortex of these rats. And so what we did was we decided to inject our rats at about 70 days of age and start behavioral testing on them a little bit later and follow them to endpoint to see whether or not this will allow them to survive a little bit longer. And so what we found, so that's our question is, does knockdown of mutant SOD1 only in the brain lead to functional improvements? And so what we saw was, it was really nice. We saw significant behavioral improvements, a delay in disease onset, and an extension in survival time. So this was really cool. And as when you're in science and you get a really cool result the first time, you really don't believe it, so you have to do it again. And so we did it again, but this time we actually added 4 more sites to the front end of our injection protocol. So now we have 20 injection sites. And what we saw was, luckily, we replicated these results. And not only, so in the first, if we consider this map and you see where those 2 added injection sites are, they're actually more in like the forelimb representation region. And in the first study, we didn't see an enhancement in motor function in the forelimb region. But this time, with the added sites, we now see a significant improvement with forelimb scores with those added sites as well. So what we did here is we stopped the study. Rather than letting them go to experimental endpoint, we stopped the study so that we could look at what was happening with the spinal motor neurons and neuromuscular junctions downstream. So when we inject this into the brain, are we seeing an enhancement in spinal motor neuron survival? And we see that yes, in this graph right here, after injections, after knocking down the SOD1 expression in the brain, we see a significant enhancement of spinal motor neuron survival. And at the same time, we see a significant improvement in muscle innervation. So these results are a pretty good indication that the brain is in fact driving disease onset. Excuse me. So what we have here is a genetic modification of a genetic rat model of ALS. Now, we wanted to go more for a sporadic type of treatment. And so the next part of my talk is about treating the brain of ALS with stem cells. And so if you have heard the name Clive Svensson, you probably know about these cells, the neural progenitor cells that express GDNF. And so these are the cells that are going to clinical trial soon for injection into the spinal cord. And so these cells have been shown to have beneficial effects on saving spinal motor neurons when injected into the spinal cord. So we thought, okay, well, what if we put them into the brain? We've seen that the brain, we can affect the brain disease onset and survival with targeting the brain genetically. What if we put these cells into the brain of these SOD1 rats? Excuse me. And so we put them into the brain. And what I'm going to show you here is so this is the motor cortex. The arrow's not really moving where I want it to move, but I'm going to show you pictures of this region. And so this is where we injected our cells. There are two, you can kind of see the two injection sites, and we see the green marker is a marker for human-specific cells. And so our cells that we're injecting into the rat brain can be identified by staining for this marker of human cells. So we see all these human cells that are in the rat brain, and they differentiate, they become astrocytes. And so what's cool about these cells is that they're not only providing support in terms of becoming astrocytes, but they're also serving as little mini pumps to pump out GDNF, which is a potent, it helps promote the survival of neurons. And so we have these cells that are in the brain of ALS rats now, and we look at GDNF expression, and we actually see that GDNF is being taken up by host cells in the region where they've been injected. And so when we do this, we wanted to look functionally. So we have an improved motor function behavior. We have a delay in disease onset with these cells, and we have a 14-day survival extension with these cells in the brain. And so, again, like any study that you do the first time and you don't believe it, you have to repeat it. So we did it a second time. And so what we found was, this time we actually put in cells that did not express GDNF. So the blue line there is just wild type, just regular neural progenitor cells, not secreting GDNF. And we see that they actually don't have a functional improvement. So it's got to be the cells and the GDNF. And so for this study, we sacrificed the rats at about 165 days and looked at their spinal motor neurons. And again, we're seeing a significant improvement in spinal motor neuron survival. So this study is ongoing. We're finishing it up to look at neuromuscular junctions and try to make it a complete story, but I think we're pretty close to finishing. And so I want to take a second to talk clinically and how this is relevant. So in the past, there's relatively little known about the brain and its role in ALS. And so many current therapeutic approaches involve targeting the spinal cord and muscle without really considering the brain. And I think we provide evidence that the brain is crucial in triggering the onset of ALS, at least in this rat model. And so this could open the door to much less invasive treatment strategy. I think locally targeting the brain with stem cells and gene therapy is much easier than getting at the spinal cord. So right now, as I mentioned before, we have these cells going into clinical trial for the spinal cord. And since this is all relatively new, we can't just go into the brain and inject these cells into the brain. But I think having the setup for these in the spinal cord, we can get these quicker into the brain if these studies prove to be valid and accepted. And with that, I'd like to say thank you for all of you for being here. Thank you for everybody else that I work with, collaborate with, and I'll take any questions.
First of all, thank you. That is just phenomenal to see that all lay out like that. From your experience, when you take a study like this, how long before it could be put into?
So a clinical trial?
Yeah. Or even just?
Well, just to give you a perspective, the clinical trial that is going on with the stem cells into the spinal cord, I think that's been in the making for a decade. However, the fact that these cells are established now and they're going through the IND with safety and toxicity as a spinal cord study, I think there's a fast track that could could go on here in terms of getting them. I don't think we're going to have to go through all of the safety and every little detail that these cells have had to get through to the point where they are now. So I don't think it's going to take that long, but everything takes a lot longer than you would want it to. Anything else?
We have a question from the internet. It starts with a comment. Thank you so very much for your informative presentation. I have a question about how patients and families can help researchers to speed up the process.
So I don't think there is really a speeding up of the process. I think you can help by, things are going to take time because of all of the regulatory aspects of everything that needs to get done. But in terms of patients helping out, it's talking to your clinicians, talking to researchers, and just giving your personal perspective and how you're dealing with the disease, what being very open and honest about your symptoms to your clinician so that all of that data can be put together so that we can make use of that in order to come up with successful strategies.
Thank you so much. Let's give another round of applause to our presenter. And we will call back to the podium Dr. John Ravits.
Okay, thank you very much, Gretchen. That was awesome. Great, very nice. I thought what I would talk about is the stages of drug development, how we actually get a drug to market, because that's what it's all about, right? Trying to find something that's going to work, and what's involved now. So I thought I'd start with the traditional pathway, and then if you want, we can talk about some of the new ideas that are floating around to see if we can break the frustration. But the traditional way of developing a drug is you go through phases of drug development. Now remember, this is the tip of the iceberg. There's decades and sometimes billions of dollars at risk for somebody to try to come up with a drug. And then you got to test it and prove it. So there's 4 phases that are generally used by the FDA. And by the way, the FDA, to me, is not the bad guy in this. The FDA is on our side. It's in their interest to get things through. But it's also in the FDA's interest to protect people, because if you remember in the 50s, there was the thalidomide, and that really, I think, kind of reset the tone, or what's the responsibility of government in terms of protection. And then I think it was reset again during the AIDS epidemic in the 80s, when there was tons of political pressure for the FDA now to move faster. So in my mind, the FDA is not the bad guy in this. The FDA is on our side, but they also have responsibility to society. So phase 1 is, so there are 4 phases. Phase 1, I'm not going to use that. Okay, thanks. Phase 1 is basically, can we do it? You got a drug, you got a cell, you've got a compound, and you want to say, can we give it to somebody? And sometimes they give it to healthy volunteers who get money for it, they get paid for it, and then you do some very preliminary studies. In ALS, which we'll talk about in a second, as a separate field, but in ALS, we give it to the patients. And then it works. We can do it, we can try to dose it, we can figure out how much we can give, and there's some very important things that are determined at that point. Then it goes to phase 2. And the purpose of phase 2 is to determine, is it safe? Theoretically, you don't look at what we call efficacy. Efficacy is, does it work? You're just looking at, is it safe to do? And and that's usually a bigger trial, more sites, everybody's got to be doing the same thing. You're trying to push the limit in terms of the drug dose, so you basically want to give as much as you possibly can to see if it's safe, so you're not doing any harm. And then if that works, you go to phase 3, where you're determining what's called efficacy, which means you're really testing it. Does it work? And then phase 4 is, I think, after it's approved. So phase 3 is the big one, because if it works there, it's a go, and then you move quickly to get it out. And then phase 4 is kind of the mop-up after it's out, and you get more experience with it as more and more people get into it. ALS is kind of pushing the limit a little bit, because everybody knows what's happening in the field, but that there aren't choices, aren't really choices. And so should the rules be different? It's kind of, maybe end-stage or advanced cancer that's escaping therapy, other diseases that are desperate, and should we do something different? And that's under a big discussion right now, because, on the one hand, we have the responsibility to protect patients. We know that some of the drugs can hurt people, but maybe the rules should be different. And there's a big effort right now to challenge that, or to see if there's some better ways to do it. And if you have ideas, then let us at it. But there is a responsibility to protect you, as well as to try to as aggressively treat you as we can. So I think those are the main remarks I wanted to make. I know there's some questions out there, so I'm prepared for them. But why don't I stop at that point?
Check. Hi, Dr. Ravits. There are many drugs that are approved for ALS, per se, in other countries. And some of them are not specifically for ALS, but they're using it for therapeutic or to help somebody either alleviate symptoms or prolong or slow down the disease. Now, in your experience, if you have a personal friend or someone you love with all the resources, still capable, all the support, and is willing because of the length of time, the amount of time they have to wait here in the U.S., and they're willing to travel, let's say Japan. Japan has a couple of those drugs. I think the Radicate and I think it's called the Ibudilast.
Mm-hmm.
Knowing what you know about those drugs, or maybe I missed something, maybe there's a third one, what would you say a good option for that person? And knowing also that this is a bulbar onset, not so advanced, first year post-diagnosis.
Okay, so I was curious what the drugs were that you're talking about, because the U.S., I think, has as many approved drugs as anywhere in the world. But if you're talking about some of these things, drugs that are being developed in Japan, is that specifically the
drugs that we can't access here, or not even our practitioners can prescribe as a therapy? Let's say the Radicate, I don't think you're able to prescribe it here, correct?
Right. I'm not sure I know that one. There's a drug from Japan.
The super antioxidant that's only intravenously applied.
Okay, but I thought that was actually published as a negative result, and then there's proceeding to get approval for it. But I confess, because I'm confused. There is a drug from Japan. The report that I read that's published in the ALS journal was that it was a negative study, and yet Japan is now seeking approval for it. So I could not cut my way through.
Mitsubishi is the manufacturer of that drug, and it's being used right now in a specific hospital in Japan, in Tokyo, as an IV treatment, 2 weeks on, 2 weeks off.
I can't comment. You will. Lucy may.
So essentially, Radicate is, that's correct. There's quite a mix that was presented at the international meeting. The effect is fairly modest and seems to be for a short period of time. There certainly is a concern to immediately think that it's going to work in another population, and in fact, the regulatory process was quite different in Japan. But there certainly is an interest to see if it could work. It's an IV administration, and so there's actually a company in Treeway who is trying to make an oral formulation of that. In fact, they have an application into us under review, but the idea is maybe to make it an easier administration because of the way it's done. And it's still questionable how large the effect is, but there is some interest in it. I think the bigger question, and maybe you can help with this, John, because it is a struggle where there is little data or maybe not easy access to something. How does one deal with that? One resource that I would give to you that's very helpful is Dr. Bedlack, and in fact Jonathan and others are all part of it, tries to address some of these particular situations by summaries of those particular things. I'm not sure if Radicat has been done. I'm happy to follow up with you afterwards. But ALS Untangled, it's a link on our site. It's an open access journal. I'm sure you're aware of that. And we help fund it. So it sometimes is helpful. It's challenging because there are various things out there that are not always clear. And to the earlier question about interpretation of the data, so essentially that's the tricky part. It's not so easy to assess the data, the value of it. It's certainly not a huge effect because then people would have seen it more obviously. And there are a few of these different compounds. So, but it's something that is absolutely appropriate to dialogue around. Certainly one of the challenges, and I think it was raised with the stem cell situation, there it's quite a different proposition where you are going, perhaps paying a very large amount of money for a treatment that is unproven. I would be very concerned about that, but it's very important to discuss with clinicians around compounds that are not so easily accessible. But maybe there's further dialogue.
Okay, yeah, so I have a couple of comments to add to what Lucy said. So I think one thing that's plagued the field forever is what we call anecdotal evidence. Okay, so when let's look at what it would take to prove, let's say you have penicillin and you want to prove it. Well, if you have a fever and you're raging and all this stuff, you can pretty easily, quickly determine that you've cured the fever. But with ALS, everybody's different. We call it heterogeneous, so it's just so different. People are going at different rates. It's in different parts of their body. It's in different mixtures, as you heard from Gretchen, between upper and lower motor neuron. It's a very complex measurement. It's actually easier in ALS than in other diseases like Parkinson's or Alzheimer's, and so it gets even more confusing for other diseases, but it's hard enough in ALS, really hard. And so, and to prove something, we have to go through these huge, elaborate studies, and everything we get is small. You know, and frankly, I don't want something small. I want something big. I want penicillin. But to get to that, we have to do these huge efforts. So that's what it takes. So the drug like Riluzole or Nuedexta, I mean, had to go through all of that process. Their effects are very modest. Okay, so now you get these reports. So what do we do with these reports? A small series, it helps. Some miracle compound, but they've tested 12 patients. You know, and so how do we deal with that? And it's a really hard challenge for everybody. But skepticism is one, because one of the things that I hate to see happen is patients being taken advantage of. So it's fine if somebody's got something that their heart is in, but it's hard when somebody is selling something and getting lots of gain at the patient's risk. So there's kind of two sides to what we're trying to do. And so it's a big effort to get these. And in the meantime, we got to do the best we can. The site with ALS Untangled is huge because it tries to take and make transparent what it is that's claimed and say, what do you got? Let's put it out there so we can all look at it. So, I mean, those are the challenges that we're all up against, but we all kind of want the same thing. You were asking about the brainstorm. I have some opinions about that. To me, the question, it's a great question if this works, but the question should be put to the company because they're making the claim, so let's get the evidence, let's look at it, and let's move it forward. We want this to work, so it's in our interest, it's in everybody's interest that if this drug works. But it's not us, it's them. They're the ones that are marketing it and developing it, and they've got the claim. So let's have at it, the way I feel about it. And let's all look at it.
A couple of things. To offer just some feedback on the Nuedexta, you had prescribed it for the pseudobulbar affect. I just wanted to report to you that it is offering some help with swallowing and speech. Minor, but there is improvement. So I just wanted to give you that feedback. Also, to follow up on what you were saying about the ibutylast, so that's an anti-inflammatory that's been there for like 20 years in Japan. They're actually doing phase 2 clinical trials. Right now, I think in Charlotte, they're recruiting right now for that. So I don't know if that's something you look at. And I was going to follow up question on that is, since it has been proven for 20 years safety-wise in Japan for anti-inflammatory purposes, and before earlier they were saying that there's a high incidence of anti-inflammatory in ALS patients. What are your thoughts on it as far as the possibility of it?
That has come up a lot in the history, is what to do when there is a approved drug for some other purpose, and then it's claimed that it might benefit ALS. And so what do? Do we use it on label or off label? And there's no right or wrong. Some clinicians will soften and will prescribe it off label at patient's own risk. Oftentimes we'll go into a clinical trial, we'll ask for volunteers, because after all, we're trying to improve history, not just ourselves. So a lot of times we'll do lithium, minocycline, they're drugs that have been approved that patients will go into and volunteer, realizing it might be a placebo, it's a placebo-controlled trial. That's what we try to do. At the same time, some patients won't accept that and want to use it off-label, and that's, if they can get it, I mean, you do what you do.
Can I make a comment? This is actually quite interesting. Sorry.
Sure. No, it's great.
So ibutylast was mentioned at the conference, and Dr. Nazem Matassi gave a lovely presentation. And in fact, the theme of inflammation came up quite a bit, and you and I were talking about inflammation. So the interesting thing about it is certainly the inflammation is something that the brain inflammation is in part a good response, it's something it's trying to repair, and in part a bad response. And so it's the balance of it, and there's quite a complicated signature of the inflammatory profile, and it certainly is variable, we think, amongst people living with the disease. I mean, it's in many neurodegenerative diseases, and some might have more of it than others. So one is to assess whether these kind of things are going to have benefit anyway, because it can vary in the population. So Dr. Nazem Matassi is doing some beautiful imaging work, and he has a way to light up the brain, so to speak, and I in fact have a slide later to show you by chance, where he's trying to see if in fact you can in real time see if there are changes, and ibutylast is one of those compounds that he's trialing. So Ben Brooks is the key person in Charlotte doing it, I believe, there, but he is adding on to it a small study to do the imaging. So I just thought that would be information to add. Sorry.
And this is actually a good time to say thank you, Dr. Ravits.
Okay, thank you very much.
Your time. And Lucy, while you're already up there, please allow us to introduce you again to Dr. Lucy Bruin, Chief Scientist of the ALS Association, and our last speaker for this marathon, Ask the Experts.
Can I get a hand here with my slides? I'm not so familiar with this computer, and it's thinking a lot. I will try, and so I am going to go with my slides because I actually had so much to say. I wanted to structure it a little bit, and I'm sure it's been a long day for all of you, lots of information. It's been a pretty packed day, 2 days for all of us with the science going on. But I think these have been really good questions, and I feel that you'll have more when you leave the room. So do feel very comfortable to contact through your local chapter or through us. Any of the things that you might have questions on. Particularly with clinical trials, it's really challenging, as Dr. Ravits alluded to. There is a lot going on. You can get to them through our website, but also on our website, we support a clinical trial through the Niels Network. We have a person, Carly Doyle, who will actually be contacted by phone. There's a number there. There's also an email address. We work together with her to try and find out which trial might work for you, what the trial means, whether it's still enrolling, because these are quite challenging things to get a handle on. And certainly there are particular criteria for you to be able to be in that trial. So if there is information that we can help with, please note that that is there, and also through your chapter or through our organization, happy to answer questions. This is it here. Thank you. And is there a pointer? It's tied to the computer. It's obviously been working too hard. I wanted to echo Clive's comments that this has really been a phenomenal summit. And I think in the state of California, you can be very pleased and proud that there's so much activity going on. Fantastic clinical centers, really good research, and many companies actually invested. And so I did want to try and give a flavor of the huge activity here. I can respect the frustration that there isn't a treatment now beyond a riluzole, but I think that just being able to go to a clinic where you have all the different parts of the disease progression cared for, it makes a huge impact. Oh gosh, that's not me. I can't speak on that at all. I don't have another backup computer. Well, I do have it to hand. Anyway, so I'll just go with it because I know that you all want to move along too. But so I really wanted to highlight the fact that through the Ice Bucket Challenge, the ALS Association, and I'm over there, that one, yes, thank you, has really had the opportunity to be able to support some major initiatives. And one of them, which really focused on while we were here as well, is the Neurocollaborative. And this is really 3 major labs. You heard from Dr. Gretchen and Clive Svensson, Dr. Finkbeiner and Ashcan is part of that team, and Dr. Don Cleveland. And it's the synergies between the different groups that really make things happen. And what is exciting is that the teams are really moving towards potential new treatment approaches that we feel in the next 3 years will be in clinical trials. So there are some trials now I wanted to mention, if I get my slides up. And as we move along, there will be new approaches. And just here in California, the whole concept of antisense technology, which was mentioned earlier, and I wanted to show some figures to explain it because it's so complicated. We're getting there. That really happened here by Ionis and by Dr. Cleveland and Dr. Smith and the group. And we're in shape. So what we did at the association over the years, and I've been with the association since 2001, was really move from just funding research projects in the lab to really helping build a global translational program. And you make good points that there is often good science elsewhere that we can really bring teams together to make it happen in partnership. I strongly believe, and our organization is really behind helping fund academic industry partnerships. I spent several years at Bristol Myers Squibb before coming into the association and saw the value of really being critical about how to move good ideas from researchers through the phases which were really nicely described to develop a drug. So those partnerships are pivotal, and you have a wealth of those opportunities in California, really exciting to see. We also help provide the infrastructure for clinical centers to be able to do these trials because, as Dr. Ravits said, we need large trials, and to do that, we need multiple centers working on them. The Neurocollaborative is one example of a consortium initiative. The Californian Summit that we had over the last 2 days was really, it's all about partnering with all the different disciplines to really make things move ahead. And so we have very strategic funding that we do, but we also ask for proposals worldwide to get ideas from everywhere. We fund in Australia, in Ireland, and in Japan, to really make things happen everywhere. And what we've been able to do, we had a fantastic opportunity through the Ice Bucket to get $115 million, but through the research programs, we were able to very quickly leverage an additional $10 to $15 million through partnerships. So this was a game-changing time, I think. And it's exciting also to know that worldwide people know about ALS, and they don't have to worry that they don't know who Lou Gehrig is because they might not be a baseball fan. So it really has become a disease known as ALS worldwide. And just to highlight again the point that there are many companies engaged with us and many partners. Genentech is doing fabulous work, has really been supporting a lot of the academic science at no additional cost to us. I didn't quite get the Frank Bennett's new logo, so it's Ionis Isis is there. But it's really encouraging to see GE as a partner, and we were involved in building those imaging tools. So I really wanted to highlight the major things that happened that was really because of the Ice Bucket Challenge. 4 big collaborations that were able to leverage, as I say, an additional $15 million. We were able to increase the investment into biomarkers, and we've used that terminology in different ways. The imaging, the challenge that it really is hard to see a smallish benefit from, whether it's stem cells or a small molecule. It's what kind of measure can you more quickly do to convincingly tell us that something has had an effect? And so we're very invested in that. We also are in the midst of an assistive technology challenge, a great partnership with Prize for Life, where we first put together a workshop, and we had some participants here in the room that were there, to think, well, what are the things that we are meaningful for people living with the disease? And so we decided our first thing would be around communication and enhancing communication technology. We got 75 ideas. We were overwhelmed with that. We had judges from both technology aspects, from people living with the disease as judges to select from those ideas. And from that, we have selected, gosh, that numbers escape me, but about 20 for application. So we'll anticipate full applications. We are reopening that challenge after the applications have been accepted and have been are ongoing. To hope in March we'll open it out again to anyone who has a great idea of a technology for communications, and we will then award that a prize towards around $400,000 to move that technology into the market, and we have particular criteria for that. We have seen over the last year tremendous increase in partnerships through the Ice Bucket Challenge. And I wanted to highlight again what is happening here, the Neurocollaborative, a fantastic partnership of 3 major labs. Cytokinetics, many of you, all of you will probably know that they've done various phases of trials. They're in the Vitality is the next trial, a big phase 3 trial. And this is a treatment that will likely help. It seemed to have an effect, particularly on the breathing, which is a very big part of it. And it's to help enhance muscle strength. So IOSIS has just announced at the end of last year, and this month has started its antisense trial. Genentech is about to announce a trial that they will be starting. Steve Finkbeiner and Justin presented. They received significant funds from the Department of Defense. This is a program that really comes through the efforts of the association and all of you through your public policy efforts. When those of you who can make it can go to Capitol Hill. So it's just in your state alone this is happening. There are many Milton Safinovitz fellows in many of the labs here, many in Don's group and in Steve Finkbeiner's group, that this is really building the future scientists who will really take it on board, and very exciting. You heard from Gretchen about the trials coming up, and this is all supported by the California Institute for Regenerative Medicine, who sponsored as well the summit, and they're in your part of the world. And then I just mentioned Treeway actually for another reason, but Treeway is a company that was formed by a person living with ALS, Bernard Muller, in the Netherlands, and together with now a team of experts, they have several ideas of treatment approaches, and one is a gene therapy, GDNF approach, which they are partnering with Dr. Svensson's lab on here in the state. I wanted to take a different approach, and I think I've got more to say than I have time for, but just to echo what you had said, And so I might cut it short. I don't know how much time do I have. I don't know who is monitoring my time. I think all the people have left who are, I can keep going, okay. So why have we battled so much? And there was a beautiful slide put up by Steve Finkbeiner today in the session, and it was just lists and lists of trials in ALS that have failed. Very frustrating. And the answer is that we don't even know that some of those trials may have had some effect, but we couldn't detect them, and maybe we didn't have the ways to do it. But first of all, when we talk about a target, and I didn't have all the time for introductory slides, whatever it is we're trying to approach, so in heart diseases you would think of blood pressure, anything that we can attempt to change the blood pressure is a good target to intervene. Have we had the right target? For ALS, the obvious targets are the mutations. We spoke of SOD1 and C9, and those are clear links with the disease. Inflammation is a much more complicated target because there are multiple components, as I said. So have we been attacking the right target at the right time? Because remember, when you see your neurologist, the disease has already been going for quite some time. So are we hitting targets that are not going to be changed because we're too late? So that's one key thing, is the target. The other is the treatment approach the relevant approach? Can we, for example, get what we need to get there? And in particular, we think of those things like GDNF, IGF-1. We call those trophic factors. They are the nutrients around cells that are good to keep them going. The challenge is, though, the brain is a wonderful thing when it's healthy. It has a system to protect things going in that we don't want in. And so the problem is trying to get drugs and big entities like GDNF, et cetera, into the brain is very difficult. So that's why stem cell approaches, gene therapy approaches are tools and vehicles to get those things there. The other, and most importantly, we've said it so many times now, is how can we measure the effect? The reason we have to have these large numbers in trials is because these small effects are hard to measure, especially in a disease, and beautiful slides that Steve and others have shown, and Dr. Ravits, the variation from one person to the other. So if you have all that variation and then you're trying to see if a drug is having effect on a varied population, it's very hard to find that effect. So we have to be clever about how we're going to do that. Have we diagnosed the disease too late? Is it going to be very easy to make a change? And certainly where we know the genetic history in families, we are going to be able to find out much earlier those that carry the C9 or the SOD mutation to come in much earlier. Again, I touched on this, the patient population. Are some people going to respond better to a drug than another? Is the inflammatory profile more robust in one particular person or groups of people than another? And very obvious. I've only got 2 minutes and I've only started. Never mind. I'll cut to the chase. But essentially, it's likely that we need multiple treatment approaches. So, and just to highlight again, as Dr. Ravits says, it takes $1 to $2 billion to develop drugs. And I'm not even going to talk about the phases that were so beautifully illustrated. Before those phases can happen, a lot of activity has to happen. And this is where I think that we as an organization, the Ice Bucket Money, and we collectively as a scientist can make a difference. Improve our understanding, identify the target more clearly. We can do this by a lot of different things. Disease modeling, we heard about the iPS cells from Ashcan before leaving. Gene discovery, we're doing huge programs on that can really help. I don't think the mouse model and the rat models are bad models. They've actually been very instructive, but they alone are not going to help us. And in every single disease from cancer to the other, any of those models have had those limitations. It's not unique to ALS. But combined modeling will do it. The worms, the flies, the iPS lines. So that's a real opportunity. And improving trials, we talked about that. We're very focused on that. And we are very involved in an initiative where many of you are engaged with us on helping the FDA guidance document, because that really will enhance how we think about the trial, the biomarkers, etc. So that's a really comprehensive view. These are the major initiatives that we've invested in. And why did we pick these things? For several reasons, but pivotal to this is central to this is people living with ALS. And in all cases, they are collecting, whether it be samples from blood to CSF to skin cell or blood for stem cells. New York Genome Center is one of two partners, Project Mine as well, that are going to be sequencing all this material. The Collaborative has a stem cell core, which is going to help put things together. ALS Act is a huge initiative, which also involves imaging of the brain. All of it is bringing a partnership with worldwide with major initiatives to better understand the disease, immediately move towards therapies, and to think better of how we actually segregate patients, so precision medicine. And not that each single person in the room here is going to get a different treatment. That wouldn't be realistic, because I tell you now the companies would not invest in ALS, but there will be groupings, and we will understand better of how we can anticipate the response of our trial. And the better our markers, the smaller our trials will need to be. So what do I tell you in a few minutes? The reality here is that all of these model systems which we invest in and can improve investment in are all valuable, as long as we connect it to the human, because that's what we're trying to treat. Actually, we're also trying to treat dogs who carry the SOD mutation. And so this has been an incredibly instructive model too, because we're getting to the point of a size that is more relative to humans. And it's also, interestingly, a model system that we can use for gene therapy, stem cell approaches that's more robust, that can be very informative. Drug development is an area that we've really been able to invest in, and I wanted to tell this one story, 2 minutes or 3 minutes over. It's been told so many times in the last 2 days amongst the scientists, and it's really quite remarkable. And that's how we as a team, and the association with really small dollars initially, and the teams of Don Cleveland and the vision of Dr. Smith, people who know him will sort of recognize he was behind New Dexter. He's behind New Dexter for speech and swallowing, amongst others. It takes a team. But antisense has been a remarkable thing. And this was something done by Ionis together with Don's lab. Had never been used for neurological disorders. In fact, the big question was whether it could even be used. And the first study that we were asked to fund, because nobody else thought it would be valuable or it was too risky, was to test the concept. So what is antisense? Very simply, when you have DNA, this is the coding in your cells, we all have it in every single cell, to get to the point that you have a protein that is the information and the functional entity in your body, you have to go through a process from DNA to RNA, and that will then be go into a protein. We knew at the time, and I worked in Don's team to do a lot of the biology around this, that SOD1, small number of cases, but SOD1 mutations in that are linked to ALS. And we didn't understand necessarily what it was that was going wrong. We knew something was going wrong. But actually, if you can block it, you could do a remarkable thing in changing the course. And so what this could do then is, by taking that small fingerprint of that protein, blocking that translation, what Ionis does is you potentially could then block the disease. And what we didn't know is if you put this into the brain or the spinal cord, that it would actually get to the neurons, because they'd never done this before. And in fact, that did happen. And so because of that, we could move it forward quite quickly, and not only for ALS, but now for SMA, the childhood motor neuron disease, for Huntington's disease, it's in trial at the moment, for Alzheimer's disease is a development, so for about 6 diseases it's being tested. And in fact, one last presentation today was an idea of how we might even use it in sporadic ALS, not for SOD, but for another potential target. So it's phenomenal what a small investment and the commitment of a small team of scientists and clinicians can do. And you asked with the stem cells, how long will it take to get there? We can't always tell how long it will get there. It took quite some time for this particular technology, but now it's moving incredibly fast, and this is how it gets administered. This is what's in trial. The fantastic thing about it is we invested $1 million to get it going, but now it's completely funded by Biogen IDEC to do the expensive trial. We are still invested in developing new ways to do other things, but so this is really what I wanted to give you a sense of, that it's a difficult disease, it's a difficult biology, but through creativity, real things have happened to find therapies, and I'm confident that with the intellect and the commitment, the Ice Bucket funds, and our partnerships, we're going to get a long way to finding the answer and treatments very soon. And I didn't have time for all of this hopeful and exciting stuff. It's the young people that will be the future of ALS, so we invest in them too, as well as the brilliant minds, and you have a fantastic opportunities and things going on in the States. So I'm sorry I couldn't do everything and tell you everything, but hopefully a few minutes of questions before everyone has to dash off. I said it all very succinctly in a rush. I'm very available. I'll be around for a few minutes now, and also through emails, through your local chapters, through your clinical colleagues. But know that there are a lot of people very committed to do everything they can to make life better for you.
Thank you.
All right. Well, thank you, everyone, for coming today. I appreciate the Golden West chapter, the Orange County chapter, and the San Diego chapter. It's greatly appreciative of everyone's time and effort, and especially our families, for taking the time to join us today. If you have any questions, feel free to reach out to your local chapter, to our guest speakers. We will have this presentation available on demand, online, the notes, speaker notes, the PowerPoint presentations. So I noticed some of you taking photos of the slides. Those will all be available online for you. So again, thank you for your time. Drive safely and have a wonderful weekend. Thank you.